A very good afternoon to all our dignitaries and attendees. It is my pleasure to welcome you all to our webinar on AIDS on behalf of Community Medicine Department, MGMIHS. I, Dr. Saili Jadhav, tutor at Community Medicine Department, MGM Medical College, also pursuing MPH final year, will be your anchor for today's webinar. The theme for today's webinar is Stand in Solidarity to End HIV. World AIDS Day is observed on 1st December each year. This year's theme for the same was Global Solidarity Resilient Services. According to United Nations, globally, 12.6 million people are living with HIV and still don't have access to treatment. The number of new people starting treatment is far below expectations due to the reduction in HIV testing and treatment initiation and antiretroviral therapy disruptions that occurred during the COVID-19 pandemic. I also invite Dr. Usha Rai ma'am. Dr. Usha Rai ma'am is our MMC observer for today's webinar. I kindly request you ma'am to join our webinar. I request all attendees to ask your questions in the chat box. They shall be answered at the end of the webinar in the question answer session. Our today's webinar shall address latest advances in management of HIV in India and global trends. For our inaugural session, I'm highly obliged to invite the Honorable Dr. Shashank Dalvi sir, Vice Chancellor, MGMIHS. Dr. Shashank Dalvi sir is eminent educationist with vast administrative experience, presently working as Vice Chancellor of MGM Institute of Health Sciences, Navi Mumbai since May 2018. He is community medicine specialist with more than 39 years of experience in government medical colleges of state of Maharashtra. During this period, he has worked as an assistant professor, associate professor, professor in preventive and social medicine department, and dean of government medical college. He has experience as registrar of Maharashtra University of Health Sciences, Nasik. He has huge experience of working on statutory bodies. He was the member of Board of Faculties, Board of Studies, Faculty of Medicine, Academic Council, Management Council, and Senate of MUHS, Nasik. He was member of Medical Council of India and worked on Executive Council of MCI for 2 years. He was Dean of Faculty of Medicine for 6 years at MUHS. Before present assignment, he was successfully completed the term as Vice Chancellor of Pravra Institute of Medical Sciences, deemed to be university from 2012 to 2017. He has worked as a principal investigator for the use of pentavalent vaccine in multicentric study of Serum Institute of India, Pune. He has more than 23 research articles published in national and international journals. He has worked on many inspection committees of MUHS Nasik, DMER, Mumbai, and MCI New Delhi. He has invited many foreign universities for academic collaboration. Sir, I request you to kindly inaugurate the session and share your thoughts with us.
Thank you very much for inviting me. Good afternoon, everybody. As this is the webinar organized by the Community Medicine Department, and I am also the person from Community Medicine Department. It is surely I make it possible to be present and share my few thoughts and give the blessings for this well-organized workshop. I appreciate the Community Medicine Department for this particular organizing the workshop. I have seen the various speakers and the topics. Those are there for this particular workshop, and those are really nicely arranged. So there will be the surely academic feast. And also from MMC, Dr. Rai has also come as an observer for this particularly the workshop. I welcome all the faculty members, the participants, MMC observer who have joined for this particular workshop. The topic title is Stand in Solidarity to End HIV. That is the apt title that has been selected for the webinar, because the HIV AIDS is in place of declining, but that decline we have to consolidate on what we have achieved and get the maximum benefit and try to end as few diseases we could end, eradicate, eliminate. So similarly, the HIV/AIDS also we can do. But as in the beginning, the Sally have mentioned regarding there are also the cases which are undiagnosed into the community. The testing is not being done. So these are really the challenges we have to find out for these particular cases. There was were an estimated 38 million people living with HIV at the end of 2019. 68% of adults and 53% of children living with HIV globally were receiving lifelong antiretroviral therapy. That means there is some percentage which is not receiving the therapy if that is needed. We could achieve nearly 85% of pregnant and breastfeeding women living with HIV also received antiretroviral therapy. That is the good achievement, but we should make it to the 100%. So all undiagnosed cases that we should diagnose them and put them on the treatment. And also due to the ART, the life expectancy has also been increased of the HIV affected persons also. The target groups that we are aware, we should not become loose with another diseases, those are coming into the picture. So the topic is also there regarding the how in the COVID-19 we can tackle with HIV. So that topic is also interesting topic. And similarly, the tuberculosis and the HIV infection, as we are planning for the elimination of tuberculosis. So similarly, the stress on HIV is also important for successful elimination of the tuberculosis by 2025. So I give all the best wishes in my this inaugural address for this particular webinar. Thank you very much for inviting me, and I will not come into the academic feast and inviting me. Thank you very much. Thank you very much.
Thank you, sir, for gracing us with your kind words and inaugurating the webinar. Thank you. Our next address is on World AIDS Day theme. Our Honorable Dean Dr. G.S. Narshetty sir has graciously suggested Dr. D. Chawla sir to conduct our session on World AIDS Day theme as Dr. D. Chawla is Medical Officer at recognized ART Center, MGM Hospital, Kamothing. Sir shall be representing our hospital as suggested by Dean sir. Dr. D. Chawla sir is MBBS and has completed his DPH. He has worked in Public Health Department of Maharashtra Medical and Health Services for 23 years. He has worked at various PHCs at rural and district hospitals as medical officer. So, I kindly request you to share your thoughts with us.
Thanks, Dr. Saili, for introducing. And as we all know that December 1, the day is observed to raise awareness among the people towards the problem of HIV/AIDS, a disease that affects the immune system of our body. And theme for 2020 of the World AIDS Day, Global Solidarity and Resilient Services. Now, as we are aware that morbidity and mortality figures indicate that this being major public health problem globally, in the wake of this, we to stand united and to bring together people around the world to raise awareness about HIV/AIDS and demonstrate international solidarity in the face of pandemic. Now it is opportunity for the people worldwide to unite in the fight against HIV, to show support for the people living with HIV and to commemorate those who have died from an AIDS-related illness. Now, as we see, there are around 38 million people living with HIV and AIDS. And out of these 38 million people, 12.6 million people don't have access to this ART treatment. And this is a quite high number. And 26 million people are taking ART That is again rise from the 2.4% rise from the last year. So being on this occasion, I would like to say that to international community to support and communicate this all the best wishes and thanks all the people who are participating in this. And with this, I conclude my thought.
Thank you, sir, for sharing your thoughts with us. Our first speaker for today is respected Dr. Prasad Vayangankar, sir. Sir is a professor and head of Department of Community Medicine, MGM Medical College, Kamote. Sir has been National Professional Officer at WHO and has worked with WHO and Government of India in eradication of polio. Sir is a member of IAPSM and IPHA and has several publications as well as conference presentations. I welcome you, sir, and kindly request you to share your presentation.
Good afternoon, everybody. Well, as Honorable VC sir has rightly said, that for the AIDS, we still need to work together globally in solidarity because this is a major public health issue still. And while discussing the various aspects of it, let us brush up our knowledge about the epidemiology of AIDS, though which are the simple things and well realized knowledge. Many of the students are also attending this webinar. So I'll be going through briefly through the topic of epidemiology of AIDS. And most of my presentation is based on the sources from WHO, UNAIDS, CDC, and NACO publications and guidelines. If we look at the background, in 1983, two separate research groups, American Robert Gallo and French investigators Francois and Luc Montagnier, they independently declared about a new virus. Gallo's group called their newly isolated virus as T lymphocyte virus 3 or HTLV3, while Montagnier's group named their isolate as lymphadenopathy associated virus or LAV. As these two viruses turned out to be the same, in 1986, LAV and HTLV3, they were renamed as HIV. What is this HIV? It's human immunodeficiency virus. That means it is infecting human beings, decrease or weaken the body's ability to fight off infections and illnesses. And obviously, it's a virus, a pathogen having the ability to replicate only inside a living cell. What is AIDS? It is acquired immunodeficiency syndrome. Everybody knows this. To come into possession of something new that is acquired, immunodeficiency means again the decrease in immunity, the decrease or weakness of the body's ability to fight infections, and syndrome means it's a group of signs and symptoms that occur together. AIDS is the final stage of the disease caused by the infection with a type of virus called HIV. So if we see the progress, the WHO HIV/AIDS classification system, then as we see in the first few weeks, the virus is inside the body, the CD4 T cell count, the immune system of the body fighting with the virus, but the viral load goes on increasing and CD4 cell count goes on decreasing. And finally, in the last stage, we call it as an AIDS, stage 4, after the minor or moderate symptoms, which may result into death. And it is a long duration. So this is a disease with a long duration, and hence we need to understand the basic principle of the epidemiology and the formula which we have learned at the MBBS level, the relationship between the prevalence, incidence, and the duration. So if the duration is long and the incidence is low, still the prevalence will be quite high. So HIV is the virus that causes AIDS. Not everyone who is infected with HIV or everyone with AIDS is infected with HIV, and AIDS is a result of progression of HIV infection. Anyone infected with HIV can still transmit the virus to another person. When we talk of the epidemiology, we talk of the distribution and determinants. Distribution in time, place, person, and determinants, the agent, host, and environment. Let us have a look at the distribution. If we see the people living with HIV, the figures of 2019, that 38 million people that are living with HIV globally. And if we break up this as per the WHO regions, in that case, we can see the major chunk is from Africa, 25.7 million, America, 3.7 million, Southeast Asia, 3.7 million, or you can say with less caseload. Then Europe, 2.6 million, Eastern Mediterranean and Western Pacific, still lesser figures. So the major caseload is in Africa. But at the same time, even 3.7 million in America or Southeast Asia is not a small number. So globally, out of this 38 million, 36.2 million adults, of which 19.2 million are women who are in the reproductive age group above 15 years, while the children below 15 years are 1.8 million. It was also estimated that newly infected HIV cases in 2019 were 1.7 million, while the AIDS related deaths in 2019 were 6,90,000. In the brackets, you see a range. That is because these are the estimated figures and they are within that range. So globally, if we see the progress, 38 million of 2019, 1.7 million newly infected, but there is 23% decrease relatively to the year of 2010. Same way, zero point 0.7 million HIV related deaths, but relatively to 2010, 39% reduction in the number of deaths. And if we see the figures in comparison with year 2000, in that case, 39% decrease in the newly diagnosed cases and 51% decrease in the deaths. That means there is a lot of improvement in the situation. But let us look globally, and the situation epidemiological principle I have explained to you about the duration and the incidence related with the prevalence. We see that there is a 24% increase related to 2010. That means the people living with HIV have increased over the years, though the incidence is being decreased or the deaths are being decreased. But at the same time, we must appreciate the efforts of our program implementers who have brought this reduction from 1990 to 2019. And then the deaths have reduced and newly infected cases have reduced because of the appropriate measures which have been implemented. In fact, it is a success of public health, we can say. As we can see from 1990 to 2019, that number of cases are being increased, or the people living with HIV are being increased. If we see the Southeast Asia, our region 3.7 million, in comparison to 2010, this 26% decrease in the newly diagnosed cases and 30% decrease in the deaths which are annually occurring. If we look at the mother to child transmission, which is an important transmission component in case of an AIDS, we can appreciate the success that there is an elimination of mother to child transmission of HIV in the Southeast Asia region. In country Thailand and Maldives, Thailand was the first country which achieved it in 2016 and followed by Maldives in 2019. Every year, 1,400 babies in Southeast Asia, they are relatively newly infected with HIV. What is the situation in India? Estimated 23.5 lakh PLHIV, people living with AIDS and HIV. 15 to 49 years, prevalence is 0.22%. Children comprised 3.4% of the total PLHIV, and the woman 15 years plus around 44% of the total estimated above 15 PLHIV. That also is a matter of concern. 69.22 thousand new HIV infections, which like in the world scenario has also declined by 37% since 2010 and by 86% since reaching the peak in 1997. While 58.96 thousand AIDS related deaths, that declined by 66% since 2010 and 78% by attaining peak mortality in 2005. The HIV incidence has been estimated at 0.05 per thousand uninfected population in India, and around 20.52 thousand pregnant women are in the need of PMTCT, that is prevention of mother to child transmission. But then, even if those figures which are showing decline for the India as a country as a whole, if we see the picture among the states, what is the prevalence in 2019? The country prevalence, as we see, is 0.22. But then there are certain states which are to the right and left of that 0.22. And as you see, the states like Mizoram, Nagaland, Manipur, they are having higher prevalence, though they are the smaller states, the northeastern states. Based on this, in 2008, WHO has decided to classify it into different types of epidemics, and then that is based on the number of prevalence which has not consistently exceeded 5% in any defined subpopulation, that is low level HIV epidemic. Then there is a concentrated HIV epidemic where the HIV prevalence is consistently over 5% in at least one defined subpopulation, but is below 1% in the pregnant women in the urban areas. And generalized HIV epidemics where HIV prevalence is consistently over 1% in pregnant women. In fact, for the program of the control of HIV AIDS, the similar principle has been utilized to classify the districts of India into the various categories. Based on this, the program interventions are being implemented. So if we see the state-wise, the caseload of the HIV or the people living with HIV in 2019, you can see it's high in Maharashtra with 17%, Andhra Pradesh 13%. You will wonder what has happened to the northeastern states which are missing here. That is because these are the states which are actually having a low population. So number-wise, they are less, and that's how they are not mentioned here. So if we see the trend, we can see definitely decline in the cases from 1990 to 2019. Let us have a look at the another country, USA. What is the situation there? Epidemiologically, the metadata is available, which shows that most new HIV diagnosed among men were attributed to male sex contact. Also, looking at the care which is being taken, 65% received some HIV care, 49 were retained in the care, while 56 were virtually suppressed. So if we see the difference between the diagnosed, recipient of care, retained in care, and the viral suppression, we understand that there is still a lot of scope in the improvement in the interventions which are to be made for the AIDS HIV control. Obviously, that will be covered by another speaker, so I'm not going into the details of that. I'm just mentioning the epidemiology. And coming to the determinants, everybody knows about this viral structure. There is an envelope, there is a core P24, and reverse transcriptase and RNA. So basically, that replication occurs in the T lymphocyte, and then that is how the virus multiplies in the body. And then, though the immune system fights initially, ultimately it gives up, and the patient succumbs to AIDS. There are two types of these HIV viruses. HIV-1 is the most common in sub-Saharan Africa and throughout the world, and has groups like M, N, and O. The pandemic is dominated by Group M. The Group M comprised of subtypes A to Z. There is HIV-2, which is lesser seen. It is found only more in the West Central Africa, parts of Europe, and rarely in India. But the HIV-1 predominates. Serologically, if we see in the host how the changes occur, the initial period is a window period where it is not detectable, and later the test does find about the presence of HIV. This takes time, and this is a unique feature in this AIDS epidemiology or any disease epidemiology, that window period is there. We usually talk about the incubation period where the symptoms occur from the entry of the pathological organism entering into the body. But then here it is different. Here it is a window period. It is a time from initial infection with HIV antibodies are detected by a single test. Usually it is 3 to 8 weeks, can extend up to 12 weeks before antibodies are detected. And it may test false negative for HIV antibodies during this time period, but the patient can still pass, or the person can still pass the virus to others during this period without knowing that he or she is suffering from this disease or has been infected by the HIV. When the epidemiology of the AIDS was studied over the years, it was identified the host factors that certain key population matters. And what is this key population? Is that the people in the population who are at increased risk, the men who have sex with men, people who inject drugs, people in prisons and other closed settings, sex workers and their clients, and transgender people. There is increased HIV vulnerability is often associated with legal and social factors, and then increases exposure to the risk situation and creates barriers to accessing effective quality and affordable HIV prevention testing and treatment services. So these factors also play a very important role. In addition, the adolescent girls and young women and indigenous people in some communities, they are also the population which need to be monitored for the presence of HIV. HIV is transmitted, as all of you know, through the sexual contact, then from an infected mother to her child, sharing infected syringe, needle, skin, and then the transfusion of infected unsafe blood or blood products. At the same time, we must be knowing about the myths and we must be knowing about the facts that a person cannot get HIV by shaking hands and embracing, touching object in phone booth or public transport, shared use of towels, linen, crockery utensils, use of public toilets, eating and drinking from same plate, donating blood, mosquito bites, hugging and kissing, and caring and touching a person with HIV and AIDS. So, to summarize, I would say that HIV continues to be a major global public health problem. There is variation in magnitude of the problem, region wise, country wise, and within country also. The knowledge of epidemiology of HIV and AIDS is well realized over the years. It's not like Corona, where we are still searching and groping for the more and more details of epidemiology of Corona. But then over the years, we have well understood the epidemiology of HIV/AIDS, and that will be helpful in controlling the problem. Reduction in incidence of HIV/AIDS is a success story of public health and should be appreciated. The end of HIV/AIDS with our efforts, even in new normal, is not far away. So let us stand in solidarity to end HIV in new normal. Thank you.
Thank you, sir, for your knowledgeable talk on epidemiology of AIDS and enlightening us regarding history of HIV virus. Thank you, sir.
Thank you.
Our next speaker is respected Dr. Shrikala Acharya ma'am. Ma'am is additional professor in Department of Community Medicine at GS Medical College and KM Hospital. Ma'am is currently deputed as additional project director at Mumbai District AIDS Control Society. She has been a faculty at GS Medical College for 23 years and has given research guidance to several postgraduates and fellowship students. She was WHO consultant for RNTCP for Maharashtra, Goa, and Karnataka state from 2003 to 2005. Ma'am, I welcome you and kindly request you to share your presentation.
Thank you, Dr. Saili.
Thank you, ma'am.
After a detailed explanation about epidemiology and the determinants of HIV transmission across the globe as well as in India by Dr. Prasad Vaingankar, I would be looking at as to how the National HIV/AIDS Control Program is being implemented and what are the successes and how is it that we now expedite the HIV response towards the end of HIV epidemic by 2030. So this has already been explained. Though India is number 3 in terms of the overall number of cases after South Africa and Nigeria, but it is a low prevalence country with only 0.22 per 1,000 cases in adult population. And we have been able to achieve significant decline in new HIV infections. Compared to global decline of 23%, we have been able to achieve 37% decline. And this has been due to the consistent efforts from Ministry of Health and Family Welfare under National AIDS Control Program through setting up these HIV/AIDS control societies across the states to have localized planning and implementation of services, not only for prevention among key population, but also to ensure treatment, initiation, and retention among people living with HIV/AIDS. The treatment, especially the rapid increase in number of people accessing treatment, has helped in achieving decline in AIDS-related deaths to the tune of 66% in last decade. You all must have heard about 90-90-90 to be achieved for the 3 diseases of HIV, tuberculosis, and malaria. In context of HIV, we need to ensure that of 90 of the people who are estimated to be HIV positive, 90% of people are aware about their status. Of those who are aware about the status, 90% of people receive antiretroviral treatment. And among those people who are on antiretroviral treatment, 90% should be virally suppressed. This is a public health goal to ensure zero new infections by 2030. So these 90-90-90 targets are to be achieved by 2020. As we saw the numbers in the previous presentation, globally, about 81% people who are positive know their status. So there are still 20% people who are not aware about their status. And this is primarily because HIV as an infection remains asymptomatic for quite a number of years. And only when the immunity is compromised, person starts suffering from opportunistic infections, the person may access the treatment and would get to know that he or she is positive. So ensuring that most of the people who are at risk of HIV infection get themselves tested is one of the important strategy to reach the first 90. The second 90 in terms of people who are aware about their status, taking antiretroviral treatment to ensure that the opportunistic infections can be prevented, the mortalities can be reduced, and the quality of life can be improved. Globally, there are around 67% people who are on antiretroviral therapy of the total. And amongst those who are taking treatment, 90% should be virally suppressed. Globally, total 59% people living with HIV have undetectable viral loads. How far we have reached in this progress towards UNAIDS targets, especially for 2020 fast track targets. 75% decline in new HIV infections from the 2010 baseline value. Though this has been reached, now for last few years, the decline is slowed down. We need to also attain 90-90. In the present lecture, we'll be seeing where are we in terms of attainment of these 90-90-90 targets. We need to eliminate transmission of HIV infection from mother to child through universal coverage of screening among ANC women for HIV. And we need to eliminate HIV/AIDS related stigma and discrimination. These fast track targets achievement would help in ending AIDS as a public health threat by 2030 as a part of sustainable development goals. As you all must have been aware, after the first case being diagnosed in 1986 in India, the task force was formed in ICMR, and the National AIDS Control Program was launched from 1992. The societies, the control societies, were formulated for all the states in 1998. The services to ensure safe blood were launched in NSCP 2, and a lot of focus on the prevention services. The targeted intervention programs were also launched in India in phase 2. treatment centers, that is antiretroviral treatment centers, and one of them being in JJ in Mumbai, was on 7th April 2004. In NACP 3 from 2007 to 12, the expansion with focus on the districts based on their the prevalence rates as it was shown in the previous slide. Across all the 586 districts in the country, the districts which had high prevalence, either ANC or one of the key population groups, were set up with the DAP2 units. Lab services were strengthened, ensuring quality mechanisms, and the gains were sustained, consolidated during 2012 to 17 in NACP 4, phase 4. And it was seen that almost more than 65% reduction in new infections were achieved since 2000 during NACP 4. NACP 4 has been extended till March 2021. And the various strategies which have been launched in 2017, April, Test and Treat has been launched, wherein the antiretroviral treatment is made available to all PLHA diagnosed, irrespective of their CD4 counts. Mission Sampark, an intensified drive to reach all the lost to follow-up patients to ensure that they come back on treatment, has been launched. In 2017, HIV/AIDS Prevention and Control Act, to ensure HIV testing through consent, to prevent discrimination in education, treatment, medical treatment services to PLHs, and to reduce discrimination, has been passed in the Parliament. And there have been efforts to ensure screening of pregnant women for both HIV and syphilis for elimination of both these infections from mother to baby. So in terms of components of the program implementation, we have the various services that have been provided under the prevention component. There are targeted intervention services for key population groups of female sex workers, men having sex with men, injecting drug users, and transgender hijra. These are considered as the source of infection, and across the Southeast Asian countries, the HIV epidemic is a concentrated epidemic with higher prevalence in the key population subgroups, which transmit the infection to their clients belonging to bridge population of migrants and truckers, from whom the infection reaches to the general population. So India has been successfully implementing the targeted intervention programs across these key population groups, and there has a significant reduction in HIV prevalence among these key population groups, which has helped in reducing the infections in general population. Designated STI/RTI clinics have been set up in most of the hospitals across the country. There are more than 1,200 such DSRCs. Knowing that HIV is an primarily sexually transmitted infection, almost more than 90% of the people who have been diagnosed with HIV infection have mentioned the route of transmission as unsafe sex. And we also need to strengthen the STI control program if we need to diagnose and cure the other bacterial and viral infections. So the DSRCs have been set up to provide quality standardized STI-RTI services using WHO's syndromic approach. In prevention program, NACO also supports government, municipal and trust blood banks through logistics support and HR to ensure access to adequate safe blood as per national blood policy. We also have vibrant information, education, communication division through mass media, mid-media and IPC. The advocacy measures are undertaken throughout the year. HIV counseling and testing services for early detection of HIV infections are set up in two formats. One setup is screening, wherein right from primary health centers, the point of care HIV screening tests are made available, and confirmatory tests through doing 3 rapid tests at standalone ICTCs are made available across all the hospitals in the country. Since last 14 years, we have treatment, free treatment lifelong for almost 14.8 lakh PLHs made available free of cost across more than 500 antiretroviral treatment centers. There is a single window delivery of anti-TB treatment and intensified case detection for tuberculosis because of their immunocompromised status. Each PLHA during their visit to ART center needs to be screened for the symptoms of tuberculosis and tested by using CBNAT for early detection of TB. The treatment for tuberculosis is also provided at ART centers. Opportunistic infections need to be diagnosed early and treated. We also provide prophylaxis through tablet cotrimoxazole for all PLHs with CD4 less than 350 to prevent PCP pneumonia. The test and treat policy, as I mentioned earlier, has been launched since 2017. State reference laboratories have been set up in all medical college, in most of the medical college hospitals in the government and municipal setup, wherein the access to and monitoring of quality services, HIV testing services at the ICTCs is monitored through these state reference laboratories. They also make panel seras for the testing and training of lab technicians at the ICTCs. CD4 testings and routine viral load testing has also been initiated through the state reference laboratories. About 63 medical colleges across the country, 64 medical colleges across the country have started with routine viral load testing for PLHs. HIV/AIDS, though it is a viral disease, it has got a lot of social parameters, and hence NACO has signed about 17 MOUs with key ministries to ensure that the services are available to the employees and stakeholders within these ministries. There is no discrimination, and there are advocacy efforts taken independently by these ministries in their own departments. Strategic information through regular monitoring and evaluation, building evidences, and implementing and upscaling based on these evidences has been one of the important pillar for effective implementation of HIV/AIDS control program in the country. So these you must have seen earlier. It has a low HIV prevalence among adult population of 0.22 per thousand population of 15 to 49 years age group. There are estimated 23.49 lakh people living with HIV. HIV infections have declined by 37% and deaths have reduced by 66%. So it can be seen that the decline is almost stagnant in the last few years, and it will take many more efforts to reach to that last mile. With introduction of ART in 2004 and rapid upscaling of the ART treatment, the AIDS-related deaths have reduced. There are around 64,000 in 2019-20. So in terms of the referral and linkages, ICTC is the major gateway entry point set up in most of the hospitals, sub-district hospitals, medical college hospitals, and either patient walk-in or referred by the doctor from all the clinics within the hospital. The ICTCs, the standalone ICTCs, has a trained counselor, social worker, and provides HIV testing facilities. ICTC also helps in screening of the clients for tuberculosis and refers these clients, symptomatic clients, for TB case detection. ICTC counselor also assesses the risk behavior of the client, and if found to have a risk for unsafe sexual or otherwise behaviors, refers the client for DSRCs also, DSRC services. Person who is diagnosed as HIV positive is linked to ART center, that is antiretroviral center, wherein the staff who are provided under the program of medical officer, counselor, pharmacist, data entry operator, staff nurse, the routine tests are done, including CD4 test, and the person is initiated on ART at the earliest. These patients are provided free lifelong antiretroviral treatment. We have the drugs. There are almost 10 plus regimens. There are drugs in first line. We also have second line drugs. And since last 3 years, we also have third line drugs which are made available free of cost to the patients. Viral load testing has been implemented since 2018 in a routine manner. Before that, it was for prioritized groups, especially for patients who are suspected to be failing their regimen. So any patients who is started on treatment after completion of 6 months of his or her treatment becomes eligible for viral load testing, and it is repeated annually for all the patients on first line regime and every 6 months for patients on second line and third line regime. So the centers of excellence and ART plus centers situated, there are around 11 centers of excellence for adult PLHs and 7 pediatric centers of excellence across the country. There are around 93 ART plus centers in various medical colleges. It has been approved now to have these ART plus centers in civil hospital ART centers to ensure that the patients who are suspected to be failing regimens or who have got other comorbidities and need to be seen by the experts panel, these are referred to Center of Excellence or ART plus centers. So the second 90, the targets under UNAIDS for second 90 and third 90, that is the 90% of patients who are aware about their status are put on antiretroviral treatment and are virally suppressed. The major task for these two targets, achievement of these two targets, are being implemented through the ART centers under Care, Support and Treatment Division of NAPO. Under the prevention activities, we have targeted interventions among key population. And who are these key population? It is the self-identified people practicing high-risk behavior of female sex workers, men having sex with men, injecting drug users, and transgender hijra. So these are the self-identified key population. However, it is a known fact that there are others who may not be registered in targeted interventions, but could be practicing high-risk behavior of unsafe sex or multiple partners and may not access the services. There could be other hidden or unreached key population who are not yet identified. So when we are looking at how is it that we reduce new infections, especially among people who are at risk of HIV infection, we need to be reaching to these hard to reach and unreached key population. The coverage and reach among these key population varies across the states in the country. In terms of the drivers of the HIV epidemic, it's a mix of multiple epidemics across the country. So in Punjab and Northeast and some parts of Bihar, UP, Western UP, the injecting drug users being the source of infection to pass on this infection to their spouses and the partners is the mainstay of the epidemic over there. While in Maharashtra, the predominant route of transmission, MSM activity has been identified as one of the important route of transmission in few urban pockets in the western parts of the country. Hence, mapping, the last mapping exercise was done in 2008 to 2011 to understand the exact population size of these key population across the states. So currently in 2019-20, this NPSC estimate is being planned and implemented. index testing to reach to the regular partners, the clients of the key population for their screening, advocacy, and if found positive, linkage to treatment would be one of the major strategy to achieve the first 90. Community-based screening to ensure reach of screening services to hard to reach, unreached key population, and differentiated service delivery are few of the approaches which are being tried, planned, and implemented as part of 95-95-95. So if we look at, this has been shared earlier, in terms of the total number of cases in the country, the state of Maharashtra has almost 17% of the caseload. In new infections also, Maharashtra has the highest infections in new infections. So the prevalence, adult HIV prevalence is 0.36 per thousand for the state. And the number of PLHAs estimated are around 3.96 lakhs, of which about 3 lakh are already on treatment in the national program. About 8.54 thousand new HIV infections are estimated, and it is highest against the states, followed by Bihar at 8,000. HIV incidence is about 0.07 per thousand population. Where have we reached in terms of 2020 fast track targets? The current status in India against the estimated 23 lakh HIV positive cases, around 76% people are aware of their status. Of these people, about 84% are on treatment, that is 14.86 lakhs. Amongst the people who were tested for their viral load in last year, 84% were found to be virally suppressed. So what are the strategies which are being planned to reach 95-95-95? As I mentioned earlier, the first 95, and especially if we have to eliminate the perinatal transmission of HIV and syphilis, if we see the coverage of ANC services across the states, some of the northern states have very low screening for HIV among ANC women, not just HIV, but also for syphilis. So universalization of testing for HIV and syphilis is one of the key target which has to be reached. It has almost been reached for the state of Maharashtra because it has very good infrastructure of 3-tier healthcare system. Spouse testing amongst the people who are found positive, ensuring that their spouses get tested, and if found positive, put on treatment. So this indicator, again, the achievement varies across the states. National numbers are around 45% spouses are tested, and about 50% of these spouses are found to be positive. So we need to improve testing amongst the spouses. And we face an issue over here, especially in Mumbai and other metro cities, amongst the migrants whose spouses may be back at their native places in those states. So it is not possible to reach those spouses to get them tested, and linked to treatment if found positive. So it is very important if we have to reach to those undetected HIV positive patients to improve the testing of the spouses. In index testing, we also need to reach to the regular partners and the other clients who may not be aware about their HIV status and could be infected. Mapping of population size estimates for unreached key population, which is currently underway. And this entails not only mapping in the physical sites, but also in the virtual media, because searching for a partner on the various apps, the mobile apps, dating apps, is currently in vogue amongst the youth population. And the same population also needs to be reached out with prevention messages and advocacy for regular screening through using social media and virtual outreach. Community-based screening to reach to the people, to provide accessible services for HIV counseling and testing in all the at-risk, for all the at-risk populations, hotspots, slum migrants is necessary to reach the first 95 target. Convergence with NUHM to ensure that HIV testing becomes a mainstay and is integrated in the package of services which are being provided through UPSCs under NUHM. For second 95, we have already seen that test and treat has been launched. In addition to the ART centers, there are linked ART centers to ensure that the treatment is continued at the center nearest to their homes at sub-district hospitals, CHCs. We have started enhanced adherence counseling for those patients who have less than 95% adherence in taking their ARVs, which can result in immunological and virological failure and does not necessarily require switch to higher drug regimens, because this is the adherence, poor adherence, which is causing the failure. So the enhanced adherence counseling that has been implemented across the ART centers in Mumbai has consistently shown that almost 42% patients did not require the switch in their treatment regimen, but were their viral loads reduced and became not detectable with improvement in their treatment adherence behaviors. The advanced disease management for PLHs who have got CD4 less than 200, especially looking for tuberculosis, extrapulmonary tuberculosis by using urine LAMP test, and screening for cryptococcal meningitis, again through POC kits, has been advocated by NACO. We have already started the implementation in Mumbai, and it would be upscaled through the all center of excellences in the country. During the present COVID times, it has been seen that many patients have migrated, have gone back to their native places, but they are registered for treatment in the cities, in our ART centers. So transferring these patients digitally to ensure that their treatments as well as the routine follow-up checkups are done at the ART center, which is close by in the same district, has been started. and engagement with the private sector, not only for reporting of ANC screening, but also ensuring access to treatment and viral load testing has been in discussion and would be launched shortly. In third 95 target, the routine viral load testing has been started since almost 3 years now. The differential service delivery models, which include multi-month dispensation for patients who are stable with improving CD4 counts and suppressed viral loads, to get dispensation for 3 months, which would enhance their retention and adherence, has been implemented across the ART centers. During COVID, we have also piloted tele-SASEP, wherein the patient's history and the treatment details are shared through digital media, either through Zoom call, Zoom meeting with the SASEP panels at COE and ART Plus centers. And the switch to higher regimens is advocated through such platforms, and the patient do not necessarily need to travel long distances to reach the SASEP appointments. So this is also going to be upscaled across the country, which will ensure that the patients who are failing their regimens can seek timely advised, expert advice, and can get the right treatment at the earliest, which will help in preventing mortality and other opportunistic infections. So this is in short. And to conclude, the rapid scale up of care, support, and treatment services under the HIV/AIDS control program has set up a global benchmark. In the last decade, the number of PLHs who are on ART has increased almost fourfold. The HIV estimations, the 2019 report, which is available on the website, has established that the country is on track to achieve the reductions in HIV-related deaths nationally as well as in many states. However, the new infections and the decline in the new infections would require more focused attention, especially the first 95 achievement, the target of first 95 of detection, early case detection through high index of suspicion, more people coming forward, normalization of HIV testing, community-based screening. These measures through advocacy, behavior change communication would require focused attention, and hence the coordinated and collaborative engagement of all the stakeholders, including the private medical colleges, the academic departments, the students, is vital to achieve these targets. Thank you.
Thank you, ma'am, for sharing your immensely valuable knowledge with us. Thank you, ma'am, for beautifully highlighting the evolution of NACO and its components, and also enlightening us with strategies for progress towards 95, 95, 95. Our next speaker is respected Dr. Mrunal Kumparkar, ma'am. Ma'am is currently working as professor at Department of Community Medicine, MJ Medical College, Navi Mumbai. Along with being the coordinator for Medical Education Technology Unit, she is also member of Academic Council and Board of Studies for MGM Institute of Health Sciences. Ma'am has a vast experience in teaching of over 20 years to MBBS, MD, and MPH students. Ma'am is also a PhD guide for students pursuing PhD in health profession education and community medicine. Ma'am, I welcome you and I kindly request you to share your presentation.
Okay, thank you, Dr. Saili. Thank you for the lovely introduction. So, very good afternoon to everyone. And today I'll be speaking on the ethical issues in HIV/AIDS. Ethics is something which many of us, we don't give too much of importance. Okay, but we really need, we mostly as a medical professional, we focus on the diagnosis treatment part of it. But somewhere we really have to look into is the ethical issues, because there are many cases, there have been many cold cases and all, and where because these ethical constraints were not was not looked into, and that's why the hospitals and the doctors were really sued by the patients. So today I would be discussing few real life case scenarios also, which have gone in the Supreme Court also. So let us have a look at the ethical issues relating with HIV. So I would be dealing into the ethical issues involved in HIV/AIDS. So friends, we all know that HIV/AIDS is not just a medical problem, but as I said, there are a lot of ethical, social, and legal challenges, okay, which we medical professionals as well as health policy planners have to look into. And this disease has most affected the vulnerable groups of the people in the world, and often leading to stigma and discrimination. So let us see what are the ethical issues in HIV. One of the biggest ethical challenge is HIV stigma and discrimination. Stigmas and discrimination are closely associated with HIV. And once a person comes to know that he is HIV positive, that forces many of the people to disclose. They do not reveal their HIV status, and thereby they are a harm to others also. And many of them even have suicidal tendencies. Now, the HIV positive status of the person should not in any way affect his right to employment, position at workplace, right to medical care, or other fundamental rights. Unfortunately, one of the biggest problems faced by HIV positive person is stigma. People, even doctors, are sometimes afraid of dealing with HIV positive persons, leading to discrimination in medical care. So this stigma can prevent people from being tested. It can result in individuals unknowingly transmitting HIV. So where is this discrimination and stigmas? These HIV positive people, they face discrimination everywhere, not just in their family, but also at the workplace, in the healthcare centers, and at community at large. They face dismissal from the job. There have been instances like there where the employer has dismissed them from the job after knowing that he is HIV positive. And so also there have been even instances like this, that HIV positive people, though they were very talented and they have achieved a lot, but still they were not given promotions just because of their HIV status. So these are all absolutely ethical issues which really have to be looked into. And because of this kind of a stigma, discrimination, remember, these people get very, very demotivated. Many of them, they go into depression. Many of them do have suicidal tendencies or commit suicide. Even many insurance companies, service providers, and employers often insist that the person has to get his HIV test first done, okay, before they give them any job. So looking into this, the government of India has given a clear notification that there should be no discrimination based on HIV positivity. Mandatory or compulsory HIV testing should not be imposed as a precondition for employment or for providing healthcare services. The Constitution of India, luckily, has guaranteed certain fundamental rights to these HIV positive patients, like right to equality. Like there are certain rights which are, even our Constitution of India have given them. Like they have a right to equality and dignity, equal opportunity at workplace. Just because they're HIV positive, they are being denied a job or a promotion or an increment. All this is not correct. So our Constitution, in fact, has given them an equal opportunity at the workplace, equal opportunity at medical healthcare centers. Like doctors or healthcare workers cannot differentiate or give differential treatment to patients who are HIV positive. They have equal rights when they go to a medical hospital for any kind of a care. Right to seek treatment and even right to marry. Other ethical issues we see when it comes to trials, when certain kinds of trials are done on HIV positive patients, be it the clinical trials or be it the HIV vaccine trials. the socio-behavioral studies which are done on these HIV/AIDS, the microbicidal trials, and the prevention of parent-to-child transmission trials. Friends, the ethical implication starts right from selection of study sites for clinical and vaccine trials. It was seen that many researchers have purposely chosen poor and developing countries for clinical and vaccine trials to avoid the ethical constraints faced in the developed world. The ethical standards should be maintained, especially when you are collecting any behavioral or biological data on STDs or HIV/AIDS. When you are doing any particular research or trial on these patients, whatever are your data collection protocols or procedures, remember measures should be taken to protect these subjects from psychological, social, physical, or economic harm. Because once the community comes to know that these are the people on whom the vaccine trials is being done or any sort of clinical trials are done, remember there is possibility that these people or volunteers, HIV positive volunteers, could be ostracized by the community. So it is very important that when you're involving them in any trials or research, you have to protect them. And that's why our ICMR, the Indian Council of Medical Research, and the Central Drug Standard Organization have established guidelines for biomedical and clinical research in India. Next, very important ethical issue comes when it comes to confidentiality and partner notification. Imagine a situation, on one side, we have to protect the right of a HIV positive individual. Okay, we have to maintain confidentiality. We have to maintain confidentiality regarding his HIV positive status. And on the other side, we also have to protect the right of that patient's partner, okay, who is to be protected from the risk of infection. So confidentiality, it is very essential, and it is one of a basic principle of our medical ethics. It is essential to maintain privacy and to prevent discrimination. So NACO, that's why, has clearly said that no person is to be tested for HIV without that person's consent. It has to be voluntary. NACO rules out any mandatory testing for HIV. You cannot force anyone, or without his knowledge, you cannot do a HIV test on anyone. It has to be proper with that person's consent. It should be appropriate informed consent with a proper pre and post-test counseling. But as I said, on the other hand, a threat is there to that patient's partner. And that's why an ethical issue arises of partner notification. So that's why, because as I said, on one side, you have to maintain the confidentiality of the HIV positive person's status. But at the other side, you also have to see that that patient's sexual partner, that person's partner, remember, has to be protected from this deadly disease. So that's why NACO has said that it is that when you are counseling the HIV positive patient, you should motivate that HIV positive person to disclose his or her status to the sex partner and counsel them to take appropriate measures to ensure that they do not transmit the infection to their partners. So remember, safety of others is also important, and that should not be compromised on account of confidentiality. So even our Supreme Court of India, the opinion of our court is also that the right to privacy and confidentiality is not absolute. This right may be lawfully restricted in situations where third parties are at risk. And to make this more clear, friends, today I'll be presenting few case studies. These are real life case studies which have actually gone in the court, and I'll present few case studies. For the sake of confidentiality, I have changed the names of the people and also the place. So let us see some case studies, and truly we will learn a lot from these case studies. So the first case study, as I said, I have changed the name of the people for the sake of confidentiality. So there was one Miss Simran, and she was to marry one person named Rohit. And Simran wanted that certain blood tests should be done before marriage itself, so that we'll come to know whether anyone is having sexually transmitted disease. And that's why Simran and Rohit wanted to go to a medical center to get the blood test done before marriage to ensure that none of them are having any STD, including HIV/AIDS. Now, Simran and Rohit were not living together, but they were engaged in sexual relationship and they were practicing protected sex. Rohit, because of request of Simran, he came to the center for HIV testing. Now, Simran was concerned about her future husband's STD status because he came from a place where the prevalence of STD was very high. So before they could get married, Simran wanted to be sure that none of them were suffering from any STD. And that's why she wanted Rohit also to come with her to a medical center to get the blood test done. Simran believed that she should have Rohit's results, and at the same time, Rohit should also have her result. And the doctor was aware of the purpose of their test and also of the Simran's concern. But over here, the doctor made one mistake. The doctor did not inform either Simran or Rohit that in the absence of their consent, okay, the doctor was legally prohibited from disclosing the HIV status of one partner to the other. So on the day of the joint consultation, Simran and Rohit, they answered all the questions about their sexual behavior in each other's presence, and both of them also gave blood in each other's presence. 1 week later, the doctor received Simran's pathology report, and Simran was negative for both hepatitis B and HIV. The next day, the doctor received Rohit's report, but Rohit was positive for both hepatitis B and HIV. A day later, when Simran came to collect a copy of her report, she was given her pathology report. But when she asked for Rohit's report, she was told that it was confidential and it could not be given to her. In the meantime, this doctor informed Rohit telephonically that he has tested positive. But this doctor did not inform Simran about Rohit's results. Also, the doctor did not take any steps to ensure that Rohit has informed Simran about his HIV positive status. The doctor also did not try to get Rohit to consent that the clinic or himself disclose this information to Simran. And now what Rohit did? Rohit lied to Simran and he told her that he is negative. Both of them got married, and a few years later, Simran came to know that she is HIV positive. So friends, the question comes now, should the doctor in his position as physician to both Simran and Rohit have disclosed to Simran that Rohit was HIV positive? So what is this case? This case is about confidentiality in AIDS patient. So here many views came. Many felt that yes, the doctor should have informed Simran about Rohit's HIV positive status. But there are many who said no, thinking that medical confidentiality is a basic principle in medical practice. And the doctor is obligated to both of them. He cannot harm one to fulfill the wish of the other. So this case went into the court, and let us see what was the court's decision. So this case came into the Supreme Court of that country, who concluded that during the joint consultation, okay, the joint consultation was with both Simran and Rohit. So the doctor should have addressed the question of mutual disclosure of results and possibility of discordant results. But he did not do so. So in this respect, there was a breach of duty was established. Also, the doctor should have secured the consent of Simran and Rohit to receiving the results together. So friends, what had happened was Rohit got a chance to deceive Simran, and Simran then suffered from this deadly disease. Let us see another case. As I said, a real case story which has gone in Supreme Court. There was one Dr. Ajay who was working as an assistant surgeon in a private hospital. And Dr. Ajay's friend met with an accident, and that's why Dr. Ajay was asked to donate his blood for his friend's surgery. So samples of Dr. Ajay were taken and he was tested. His test showed that Dr. Ajay was HIV positive. But till that time, Dr. Ajay was not knowing that he is HIV positive. 2 months later, Dr. Ajay proposed marriage to Miss Anita. And Dr. Ajay did not inform Anita that he is HIV positive. Anita accepted the proposal and the wedding was scheduled for 6 months later. However, when the hospital came to know that Dr. Ajay was getting married to Miss Anita, the hospital informed Miss Anita's family that Dr. Ajay was HIV positive. Knowing this, Miss Anita's family called off the marriage. And as the marriage was called off, Dr. Ajay's family and the entire community came to know about Dr. Ajay's disease. Dr. Ajay was severely criticized, ostracized by the community, and forced to leave. So Dr. Ajay then sued the hospital. He claimed damages against the hospital on the grounds that the information which, according to our medical standards, should have remained confidential was illegally disclosed, according to him, and therefore he sued the hospital and the hospital was liable for damages. So, friends, what do you feel? Should the hospital have informed Miss Anita's family that Dr. Ajay was HIV positive? So what is this case? This is a case of information, medical confidentiality, and its limitation. So what do you think? Should the hospital have informed Miss Anita's family that Ajay was HIV positive? Many of them felt no. The hospital has a duty to maintain confidentiality. So by disclosing a confidential medical information, it is kind of a breach of trust between the doctor and the patient. So many of them felt no, the hospital did not were not ethically correct. However, many of them said yes, that confidentiality, remember, definitely is one of the principle of medical ethics, but it is a basic obligation. It's not an absolute obligation. And one of the exceptions, there are exceptions, that obligation in such a disclosure of confidential information will save innocent people such as Anita and spare them of exposure to this dreadful disease. So what was the court's decision? The court also said that the general rule of confidentiality is not absolute. It contains exceptions which permits disclosure with the consent of or in the best interest of the patient where the public interest so requires. So over here, the hospital won the case. So as I said, confidentiality is one major ethical issue in HIV. And now let us see what are the other ethical issues. Other ethical issues comes in case of HIV positive women. Can a HIV positive woman have the right, or is it ethical for her to become pregnant? Can she conceive? Should she conceive? Should she give birth to a child? So there are a lot of ethical questions. These are not just medical problems, but also ethical aspects are involved. So remember, HIV positive women should have complete choice to make decisions about pregnancy and childbirth. They should not be forced to abort. If she wants to keep the child, she should not be forced to abort or even sterilization. Proper counseling should be given to the pregnant woman to enable her to decide whether to continue or terminate the pregnancy. So friends, regarding this also, there is one very interesting case, as I said, a real life case which went into the court. So names changed again for the sake of confidentiality. So what is this case? There was one lady named Jyoti, who was a 32-year-old woman. She had a long relationship with a man. She did not marry that man, but she had a long relationship with one man. And one fine day, that man told her that he is HIV positive. So knowing his status, Jyoti immediately got herself tested for HIV, and the result came that even Jyoti is HIV positive. Jyoti, knowing this, then started upon a regime involving therapy. She took proper medical therapy. She went on a strict diet, a healthy living. So in spite of she was HIV positive, still for many years she remained fit. Many years later, Jyoti then met a man whom she fell in love. That man was HIV negative, and both of them decided that they would want to have a baby, that they would try to conceive a child, and 1 year later, their daughter was born. Now, Jyoti was HIV positive, and she gave birth to a daughter. As we all know that there are 25 to 30% chance that the child would be born HIV positive because the mother was HIV positive, the doctors felt that the child should be tested for HIV. And in the meantime, Jyoti was also breastfeeding the baby. So we all know that even via breast milk also the HIV can be transmitted from mother to the baby. Now, if the baby was HIV positive, then obviously Jyoti could have been continuing the breastfeeding. But if the child was HIV negative, then medical experts thought that it would be better that if she doesn't breastfeed, it's up to her. But the doctors strongly felt that the child should be tested for HIV. Despite repeated requests from the medical staff, the parents refused to get the child tested for HIV. Now, friends, should the child be tested for HIV despite her parents' refusal? What is this case? This is a case of treatment of minors, the patient's well-being. So imagine this is the case of a child. A child cannot give consent for anything. And it is the parents who always take decision for the child. So on one side, it is the parents who are not giving permission for the child to be tested for HIV. And on the other side, there are doctors who, for the child's sake, well-being, want to get the test done, HIV test done for the child. So again, this case had gone to the court. And should the child be tested for HIV? Many of them said yes, because by doing the test, we would come to know whether the child is suffering from this serious disease or not. And once a diagnosis is done, then obviously treatment could be done. But there were others who said no, because the parents, they thought that parents have the right to determine the course of treatment for the child, and nobody can force them to act differently. So this went into the court. And what was the court's decision? So this case came before the Supreme Court of that country, and the Supreme Court concluded that the child's medical condition, if it's unknown, then clearly the child is at risk. Since there are 25% chance that the child will be HIV positive, okay, and this risk is being increased because of breastfeeding, it is very important to know the status of that child so that accordingly the treatment can be started to the child. Friends, the Supreme Court said that in every medical procedure, the patient's well-being is of utmost importance. And here the patient, remember, is a child. So when it comes to a minor, infant or adults who are not able to give their consent to the treatment or to refuse, in that case, an evaluation must be made as to whether the decision indeed serves the objective of well-being of the patient. The right of the parents is definitely there on their child. It is their right to take decision for their children, but it's definitely a conditional right. But on some occasions, when a parent's view, okay, of what is in best interest of the child can differ from that of the clinician, in such situations, the clinician is the best qualified person to tell what is good for the child, or in the child's best interest, what should be done. So in this case, obviously the doctors won the case, and the Supreme Court also said that for the well-being of the child, it's important to get the HIV testing done. So let us look into what are the other ethical issues. There are issues like people discuss about mass screening of all the patients admitted in the hospital. So should all the patients, whoever come to the hospital, should they be tested for HIV? So obviously that mass screening and indiscriminate testing of patients is not allowed, because it's never completed, it's not cost effective, and obviously those today who are negative could get exposed subsequently. So also there are many questions asked that should mandatory testing of HIV be done before marriage? Like before, a couple could get married, it's good that ideally we say that yes, it's good that if we do HIV testing of both, obviously it will save the life of one if someone turns out to be positive. But again, currently mandatory testing of HIV before marriage it's not mandatory, and though we say it's ideally, but it's not mandatory as of now. And mandatory screening is done when it is done permitted in case of screening of blood and blood products before transfusion. Next ethical issue is relating with women and gender inequality. We all know that today we are living in a male dominating society. And friends, the unequal status of women also makes them vulnerable to HIV infection. Many a times the women, when they suspect that their sex partner is having a high risk behavior, and when they insist them to wear a condom, but it may so happen if the male is refusing, many a times the women have no say. And that is the sad story, especially in a country like India. And we see this even with commercial sex workers. They are willing to adopt safe sex practices, but their clients object. So many a times the CSWs are not in a position to say anything, and that makes them vulnerable to HIV. But of course, now we have a lot of success stories where many organizations have worked with the CSWs and interventions with them. Remember, when CSWs have been able to convince their clients to adopt safe sex practices, that has really brought down the incidence of HIV in them. So lastly, let us have a look at the HIV related legislations. So friends, remember as I said, HIV positive people, they face a lot of stigma and discrimination, a lot. And therefore, certain constitutional rights have been laid to safeguard their equality and dignity. But what is really still lacking is there are no special laws or specific laws to safeguard their interest. Of course, there are lots of provisions in the Constitution. Like Article 14, it guarantees the right of equality to treatment to the HIV/AIDS patient. Article 15 and 16 protect them against discrimination. Article 21 protects their right to life and personal liberty and ensures their right to privacy. Article 39 directs the states to ensure that all citizens, including HIV/AIDS patients, have an adequate means of livelihood. And Article 42 casts a duty upon all states to make provision for securing just and human conditions at work. So definitely certain articles, certain provisions are there. There is one welcome legislation, that is the HIV/AIDS Bill 2007, which specifically prohibits discrimination of HIV/AIDS patients in public as well as in the private sphere. So this prohibits discrimination of HIV/AIDS patients which relates to employment, their education, their health care, travel, insurance, residence, property. Okay, so no one can discriminate them just on the basis of their HIV/AIDS status. But still, there has to be certain more special laws which will safeguard them. We as healthcare people, it's our duty to follow a code of medical ethics, because even in our day-to-day practice, we have to deal with many questions of confidentiality, whether to share their HIV status with their family, with other healthcare professionals, with spouse, partner, how to, regarding the maintenance of their medical records, their consent, the treatment referral related issues. So we are definitely blocked with various ethical questions. But ultimately, our code of medical ethics states that our principal objective is to render service to humanity with full respect for human life. And we doctors definitely should maintain very high standard of medical care and support. It would be really very unethical on our part if we refuse treatment, okay, to a patient just because we can get risk if we are performing surgery on any HIV positive patient. So that's why just because of that risk, if we are refusing a treatment to any or investigation or procedure or surgery to any HIV positive patient, it's very, very unethical. And also it's very unethical for a doctor who is withholding the treatment just because he is judging the patient that you have got this disease because of your lifestyle. Okay, so giving such kind of a judgment or judging them like this is really very, very unethical. And such kind of unethical behavior, friends, will raise question of serious professional misconduct. So ultimately, we have to follow the principles of medical ethics, which is autonomy, beneficence, non-maleficence, and social justice. So I conclude now by saying that, friends, although, as I said, certain constitutional laws and notifications bill are there, and that definitely provides a lot of relief to people living with HIV/AIDS. But still, if we want to eradicate all the stigma and discrimination, okay, they will have to be addressed with certain special legal provisions. So community and social organizations have definitely an immense role to bring an end to prevailing stigma and discrimination. It's very important that we should understand the ethical and societal concerns, which will go a long way in development of appropriate policies for disease prevention and control. And promoting social, behavioral, and legal research will improve understanding of the dynamics of this disease and its impact. So thank you very much.
Thank you, ma'am, for your insightful session. Thank you for highlighting the importance of ethics in HIV cases and showing interesting case studies, and also highlighting stigma faced by HIV patients. We shall be conducting a small question answer session right now. I request Dr. Shrikala ma'am to address these questions, please. Ma'am?
Yeah.
Yes, ma'am. Ma'am, the first question is, what indicators are decided to determine the achievement of elimination of AIDS-related stigma as mentioned in 2020 targets?
We actually do not have any indicators to measure the progress towards end of stigma. However, UNAIDS has devised some scales which they routinely offer to PLHs in the countries, and based on the scale in terms of the discrimination at schools or workplaces or the healthcare settings, the questions are based on these settings, and it is offered on a random basis to key populations or to PLHs. And however, the target as such and how to measure the progress has not been at present existing under the elimination goal.
Thank you, ma'am. Ma'am, the second question is, how should we improve treatment literacy and adherence among people living with HIV?
Yeah, this is very important, especially because the treatment needs to be taken for life, for the entire life, and the person may or may not have symptoms of the illness. Sometimes the medicines can cause the side effects, and the person may feel that I was much better before starting the treatment. So the importance of taking lifelong treatment on a regular basis is very important. We also need to understand that patient may feel stigmatized and may not be feeling confident to disclose one's status with the close family members, partners, spouse, etc., and may then skip taking the medicines also. Person may also have a lot of mental health issues because of the awareness of his illness and not being able to share that information and seek comfort, mental comfort, emotional comfort from others. So these are the various challenges that a newly diagnosed PLHA may face, and we need to address these issues through counseling. The counselors at ART centers are trained to deal with these issues. Right at the pre-ART stage, that is when the patient is diagnosed and undergoes the basic biochemical investigations, study 4, the information as to what does the illness mean and why the person needs to take the treatment is provided as counseling session of 1-to-1 around 20 to 30 minutes. In addition to this, because patient may not open up and come with his or her questions to the counselor, especially in overcrowded settings in medical colleges, etc. We under MDAX have also launched an mobile app with animation videos. It is called as Zindagi app. And it has these animation videos on various themes, less than a minute video, which patient can download on one's mobile and see and get used to learn from these videos. And it requires good emotional support from the caregivers, the family, sometimes at the workplace also. We also have a lot of patient support groups through network of positive people, who also have group meetings to improve the treatment literacy, their awareness, as well as their motivation to continue to take the treatment.
Thank you, ma'am. Ma'am, the last question is, how do we approach treatment defaulters?
We do have, the patients miss their appointments at the ART centers. Sometimes they default. There could be various reasons for defaulting, right from economical to not feeling the need to continue to take the treatments. There could be side effects. So there can be various reasons for defaulting on the treatment. We need to, at the ART centers, the mechanisms that has been followed is basically to check their adherence for the existing treatment, adherence status. If the person is defaulting in between taking the treatment, they are counseled. The reasons for poor adherence are assessed. If the person has missed coming to the ART center totally, the person is contacted on the mobile number or the phone number that has been registered in our ART centers. We also have a system under NACO, wherein care and support centers have been set up, and the peers who are themselves HIV positive persons, many a times, they contact these defaulted patients at their homes, counsel them, and get them back to treatment. They also address the reasons why the person has stopped taking the treatment, so that we can take the appropriate measures to alleviate these issues.
Thank you, ma'am, for answering our questions and queries. Thank you so much.
Thank you.
Yes, Dr. Saili, I think it was nice to have few questions in between these sessions, and I hope that the queries which have been answered by Dr. Shrikala, the participants must have satisfied. I think we can proceed with the further session.
Yes, sir. So our next speaker is respected Dr. Madhvi Mankar, ma'am. Ma'am is an associate professor at MGM Medical College, Kamothi, Navi Mumbai. Ma'am has worked as RSTC in charge and has vast experience of development of rural health training center management. Ma'am has several national and international publications and has presented in several conferences. She has guided many undergraduate students for ICMR STS projects and has played a key role in department NAC accreditation process. Ma'am, I welcome you and kindly request you to share your presentation.
Thank you, Dr. Saili. First, I would like to express my sincere thanks for giving me opportunity for today's webinar. Today's my topic is HIV/AIDS control in new normal. And in this context, new normal means whatever we all are doctors and health workers are facing the pandemic of COVID-19, and all of us has faced a lot, and we are waiting when it will stop.
It has a great impact on our personal, social, and psychological life. So as all the health programs for the communicable and non-communicable diseases also, it has a great impact. And how this HIV/AIDS control program is running in this COVID-19 pandemic, that we are going to discuss here. First, I would like to overview regarding the COVID-19. Next. The first case of COVID-19 appeared in Wuhan, China in December 2019. It is a highly contagious disease with a higher reproducibility. Even 20% of the cases cause about 80% of the cases, and it has a reproducibility about 2.3. That means within a week of time, it increases the double number of the cases. COVID-19 has spread quickly throughout the world, and about 218 countries are affected by the COVID-19. It results as a mild illness for the most of the cases. But the people who are in older age group and have a pre-existing condition like diabetes, hypertension, renal disease, or bronchial asthma has a severe illness or death. Most of the healthcare system in many countries are taxed, particularly the countries who are developing and where the higher infection rate, they are taxed more. Now coming to the how the COVID-19 occurred, the cluster of pneumonia cases of unknown origin in December 2019 in Wuhan. And then when they epidemiologically investigated, out of 41 patients, 27 had exposure to seafood market. Then gradually, when we have seen the timeline, on 12 December 2019, Wuhan reported the first case. Then gradually, on 31st December, Chinese authorities alerted WHO about the cases of pneumonia of unknown etiology. When they found the correlation between the seafood market and the COVID and this novel coronavirus disease of unknown origin, so on 1st January 2021, seafood market was closed. On 7th January 2019, WHO found this novel coronavirus is the cause of unknown etiology of this pneumonia. And the first death in this period occurred on 12th January. Out of China, when the first case occurred, that is in Thailand on 13 January, and on 30th Jan, India confirmed the first case, and that day the WHO declared it as a public health emergency of international concern. On 28th February, WHO declared it is a regional global risk and it is very high risk. On 11th February, WHO declared this virus as a SARS coronavirus 2 and the disease is COVID-19. The 3rd March, about 74 countries had a local transmission. Currently, if you see on 9 December 2020, 6 crore and 77 lakhs 80,361 confirmed cases of COVID-19 are there, and more than 15 lakh 51,000 deaths are there in 218 countries. And we in India, we have about 97 lakhs of confirmed cases and 1,41,772 deaths of COVID-19. So if you see the epidemiology of COVID-19, the agent is coronavirus belonging to the large family of RNA virus. It is a zoonotic disease. Most of these viruses are very common in animals like camel, cats, and rats, and they can transmit the infection to the human. The etiological agent responsible for the present outbreak of COVID-19 is SARS-CoV-2, which is a novel coronavirus. It has a genetic similarity to the SARS-CoV-1 and COVID-1 virus. Transmission of coronavirus can occur through the respiratory secretion, and the incubation period of this coronavirus disease is 2 to 14 days. Most of the patients present with the fever, fatigue, dry cough, and breathing. And in 20% of the cases, patient may have the gastrointestinal symptom like diarrhea, nausea, and vomiting. If you see the coronavirus transmissibility, mostly it is transmitted through the infected droplets, aerosol, contacts. Through the infected droplet, if the droplets are more than 500 micrometer, it can travel less than 1 meter. But if it is less than 5 micrometer in size, it travels more than 1 meter. And through the airborne, through the droplet, and through the direct contact like through the hands and the surface, the susceptible patient can get the infection. Now, just I would like to give the overview of the epidemiological insight. Most of us are going through this. We knew this knowledge. At the diagnosis, approximately 80% of the cases are mild to moderate, 50% are severe, and 5% are critical. If you see the disease progression, approximately 10 to 50% of the mild and moderate cases become severe, and approximately 15 to 20% of the severe cases can become critical. If you see the average time of exposure to the development of the symptom, it is about 5 to 6 days after the infection. From symptom to the recovery for a mild case, it takes about 2 weeks. And from symptom to recovery for a severe cases, it takes 3 to 6 weeks. From symptom of onset to the death, it's for 1 week to 8 weeks. Fortunately, COVID-19 is much less frequent in children than adults, and children tend to have a milder disease. This is the situation of the COVID-19, and we are all dealing with the COVID-19 and how to control this COVID pandemic, and different strategies are there for the containment. And in this scenario, we have the earlier communicable disease programs are there, and in which National AIDS Control Program, it is the most important program, and about more than 23 lakhs of people we are having living with HIV. So although the global attention is dominated by COVID-19, the HIV/AIDS pandemic, it enters in its 5th decade. And again, it is still far from over. Since early 1980s, we have 75.7 million people become infected with HIV, and 32.7 million people have died from AIDS. HIV/AIDS remains a major public health crisis, and very few countries will achieve 1919 target by 2020. As in HIV/AIDS control program, we have a proper organization, we have a proper infrastructure, and the service model are available in India. And this really helps us to tackle the COVID-19 response, because we have up to the outreach level, we have the people working for the control of HIV/AIDS. But still, COVID-19 pandemic could have a knock-on effect on HIV response, and it could be devastating for the communities. So the question arises, will we reach towards reaching the goal of ending HIV/AIDS by 2030? If you see when the COVID-19 pandemic occurred before 9 months, we were in a very bad condition. COVID-19 pandemic has strained our health system and exposed the gaps in public health almost everywhere. If you remember that time we were lack of resources, infrastructure, we are lack of equipment and the medicine. And even the health worker, the MBBS doctor, we are scarce of resources. We involve the dentals, BDS doctor, we involve the BMS and BHMS doctor for giving services, and that services for identification, for quarantine, for isolation, and for involving the other doctor from the alternative medicine for giving services in COVID-19 pandemic. So we are in lack of resources. From the highest level of national leadership to the community-based health facilities, human, financial, and research resources. Also, it has been diverted from the HIV control program to the COVID-19. There are several studies suggested that disruption of HIV services could have a negative effect on the health outcome in medium and long term. The data was being published in Lancet Global Health. It was a modeling data, and it suggested that because of the severe treatment disruption in high burden setting like South Africa could increase the HIV mortality by 10% within 5 years. So again, this is a very alarming situation. If you see the global initiative to control HIV pandemic, this is UNID has given us a 2020 fast track targets that we should 90% of the people living with HIV, they should be aware about their HIV status. And out of 90% of the people should be on ART treatment, and 90% should be virally suppressed. The SDG has given the target 3.3. That is, our aim is by 2030, we should end the HIV epidemic. So are we able to achieve this target? That is again a question. If you see the 2018 target, So 79% of, this is the current situation in India in 2018, 79% of the people were aware about their HIV status. Out of 79%, only 71% were aware about, they were on the HIV, that is ART treatment, and we were not having the data about the virally suppressed individual. This is the current data in 2019. That is 90% of the people, out of 90%, 76% in India, people are aware about their HIV status. Out of this, 84% people are on ART treatment and 84% are virally suppressed. So again, this is again giving a good sign regarding the control of HIV. If you see the HIV patient with living with HIV, as we are aware that they are immunodeficient, and again they have a usually high risk of complication with any opportunistic infection, and it is true for the COVID-19. When it has come, people were thought that there will be more cases of HIV with COVID-19, but we have a very less data regarding HIV with COVID-19. Up till now, there are about 6 reports of HIV with other coronavirus co-infection being published. And recently in 2020, we have data from the China. And it suggested that the people living with HIV/AIDS had mild to moderate coronavirus disease despite of the severe immunodeficiency. And all of them are recovered well. The people living with HIV who has the low CD4 count and the COVID, they have the similar outcome as compared to the people who do not have the HIV. So people thought that now this is a research question, will the defective cellular immunity in HIV infection could paradoxically be protective factor for prevention of COVID? Or is there any role of protease inhibitor, that is the patient living with HIV/AIDS having put on the antiretroviral therapy, having some role against the prevention of COVID-19? So again, the research is going on all over the world, and up till now there are about 25 registered trials are there. And these trials are going on about the efficacy and safety of antiretroviral therapy for the treatment and prevention of SARS and COVID-19. By studying all these things for the treatment, again, because of the small sample size and insignificant, statistically insignificant result, they got a good result, but still we cannot say that it is because of the ART treatment, that is because of the lopinavir and the ritonavir. These are the 2 drugs they have used for the finding out their efficacy in the treatment. For the prevention, also they have tried the HIV with the COVID-19 patient, and still these registered trials, they have the because of the sample size, we cannot say that it is the statistically significant result. But again, it is a point of research. Now coming to the HIV COVID-19 fact sheet, which has been published by the WHO. And according to the fact sheet, whatever the things we should be knowing is that the people living with HIV and on effective antiretroviral treatment are not at a greater risk of getting coronavirus. Current evidence suggests that HIV is a less risk factor for severe COVID-19 than other conditions like diabetes, hypertension, bronchial asthma. People living with HIV but not on treatment or the virally not suppressed may be at a greater risk of coronavirus, COVID-19. As with general population, it is similarly true for the people living with HIV, that the older people and who are having the underlying health condition like diabetes, hypertension, they have to take an extra precaution to prevent the illness. At least they should be having the 30 days buffer stock of ART at their home, and if possible, where the resources are available and where the stock is available, at least 3 months stock for people living with HIV in this pandemic situation. Remember, all the people living with HIV, they should be in touch with the healthcare provider, and time to time they should take the advice from their clinicians, maybe online or through the telemedicine or telepath. Now, are some people living with HIV more at risk of getting illness? Yes, the people living with HIV who are having the low CD4 count, that means less than 200 copies per cell, high viral load, and or a recent opportunistic any infection like diarrhea, tuberculosis, ARI, they will be having a higher risk of developing COVID-19. What are the risk factors for COVID-19 severe illness in people living with HIV? The person who is more than 65 years of age, cardiovascular disease like including hypertension and diabetes, chronic lung disease, heavy smoking, immune suppression, and oncological treatment. Now, what are the challenges faced by people living with HIV in COVID-19? As a normal individual, we have faced a lot. We first time seen a lockdown as one of the important strategy for containment of COVID-19. In India, we have almost from 22nd March to 30th June, we had a lockdown, and gradually we 5 times we had a unlock India, and more than 1.3 billion people, Indian people, were in lockdown position. So if you see the people living with HIV, mostly we have the key population, they are earning their livelihood. This sex worker not getting treatment properly, or they are not getting the clients, and they are not having many problems. They were not having food, whoever not having shelter. So in that situation, this pandemic itself has created a risk to the people living with HIV, and along in addition to that, their HIV status where they have a higher exposure or increased exposure to the risk to the COVID-19. So the situation itself is one of the challenge. Then anxiety because of the situation, uninterrupted supply of drug, whether they will be getting drugs or not, because these are the people living with HIV patient. They are lifelong put on the ART drugs, and simultaneously many patients develop the side effect because of the second line and third line drugs. So the challenges were there. Loss to follow, many patients gets defaulted or migrated because of the lockdown, and they were not knowing where to get their drugs, where are the ART centers. So these are the things where there. Other issues like voluntary counseling and testing, whoever having the high exposure or unprotected sex, whether they will be getting counseling and testing, post-exposure prophylaxis, and access to HIV preventive. This is the most important one of the strategy to prevent the control of HIV/AIDS in India and most of the country. That preventive services like, for example, the harm reduction, like getting condoms, lubricant, and the injection and syringes. Again, this would be a problem, and these are the challenges faced by the people living with HIV/AIDS. One study has been conducted in Hubei, China. This was a survey done in 1014 people living with HIV, and after this survey, about 32% of the respondents said that they were not carrying sufficient antiretroviral therapy or medicine to meet the needs because of the traffic, travel restriction, and because of the hesitant that they may get the HIV infection, or some could face a stock out in the coming months. 64% of the people living with HIV reported that they were having a difficulty in accessing the ARV due to the restriction, and 28% respondent were in the need of the socio-psychological support. So again, the anxiety, the depression, and is associated with this COVID pandemic. Now, this is the one study been published by UNID's 2019 in sub-Saharan Africa. The 5 research centers they have taken, and this is the mathematical modeling they have done. And it is said that what is the indirect effect of COVID-19 on HIV? This is the cost of inaction. If the HIV services are completely disrupted, because of the COVID pandemic, and if 6 months the treatment is not being given to the people living with HIV/AIDS, what will happen? So it will increase this is the impact of interruption of the treatment for 6 months. So this will increase 1 million deaths more than what is expected. So the death rate will be high. If mother-to-child transmission, these services are disrupted or not given for 6 months, it could result into the dramatic increase in new HIV infection. So this is the study. This is the mathematical model prediction, which shown that because if we not given the treatment properly, or if there is in an uninterrupted, if it is there is interruption of the supply of the drugs, then there will be increased mortality as well as there will be new HIV infection among the children. So that's why WHO given the guidelines that maintaining essential health services for people living with HIV/AIDS during COVID-19 pandemic is must and mandatory. Because whatever the services in people living with HIV, especially the commodities like the normal, that is the syringes for IV drug users and the condom and the lubricant, these are the basic and these are the basic things that should be available, and these should be included into the essential health services. So WHO recommends that the practical measures should be taken at the national, subnational, and the local level to organize and maintain the access to the services in a full safety and the highest quality. And they describe that it should be divided into the operation strategy to maintain the essential health services and the specific information. While giving the essential health services, the specific information should be given regarding the COVID-19 to the people living with HIV. Now, these are the guidelines in COVID-19 pandemic. Government of India has given to the all the National AIDS Control Program and all the centers. So these are the general advisory for the people living or with HIV/AIDS and visiting to the National AIDS Control Program facilities. All are requested to abide the whatever the guidelines are given by the MOHFW and in respect to the COVID-19 protocol for the patient's referral, testing, and clinical management. Then they said that whenever the patient coming to the NSCP facility, they should take the adequate precaution like social distancing, hand hygiene, respiratory etiquette, and avoid the unnecessary travel. All the NSCP centers, IRT centers, they should be having the IC material for the prevention and containment of the COVID-19, and it should be translated into the local language, and it should be widely disseminated and displayed at the NSCP facilities. Again, regarding the ART treatment dispensation of people living with HIV, this is called the multi-month dispensation. The 3 months multi-month dispensation may be given to all the stable patients living with HIV who are on first line and the second line ART, along with IPT, that is ionage prophylaxis, and cotrimazole prophylaxis as per the existing guidelines for the multi-month dispensation. MMD guidelines should be followed at all ART center, all the facility integrated ARTs, and the link ART center. Dispensation of the ATT, that is the anti-TB drug for HIV with TB co-infection, that how the drugs can be delivered at the community level. So Government of India has given the recommendation for the community dispensation, and we have the proper network, that is a peer HIV networks. We have many NGOs are working, and many centers are there, and we have the outreach worker for HIV. They are playing a very important role for community dispensation of the ART drugs. So strategies like community dispensation through the care and the support center, home delivery through the outreach worker, volunteers, and we have a people living with HIV network, and the family dispensation should be allowed in this COVID-19 scenario. We have the patient who are on the opioid substitute drugs should be distributed at least 7 days to all the patient. The commodities like to the people living with HIV, and we have the key population, they should be provide multi-week, at least 2 to 3 weeks dispensation of the commodities like condom, needle, and the syringe. And all the key population should be avoided to travel and decrease the frequency to the frequency of visit. Now, these are the just glimpses of how the community distribution of the ART drugs, as well as the different commodities for the harm reduction in HIV/AIDS control program. There are many NGOs are working. We have the Human Touch Foundation and National Coalition of the People Living with HIV in India. How this peer group HIV people are giving ART at home. These are the strategy like harm reduction. We have the condom, syringes, and the lubricant are also provided. The people who are injectable drugs, even and IV drug user, They are also again syringe dispensing machines are installed, and through that also syringes being provided in abroad. So again, this is one of the things that the people living with HIV, they can contact their they can contact the consultant by online consultation. They can have a through the WhatsApp. They have a different link also. And in Mumbai, we have the Sase, which Dr. Acharya, she has mentioned in Mumbai, they have this consultation. And through that, again, people living with HIV, they can discuss their case, and if they have any side effect, or currently if they have some symptoms regarding the other disease also, they can discuss. HIV self-testing, again, it is a very innovative thing. This is a testing done by the patient itself, but again in India it has not been rolling. But we have the Africa and UK and US, they have the HIV self-testing, by which again the preventive measure and again early diagnosis of HIV can be done, and patient can be put on early on antiretroviral therapy. Again, ART treatment can be delivered by the courier, by mail. Again, the opioid substitute drugs are also given to the patient take-home basis. So this is again helping the people living with HIV and reducing their anxiety about the HIV/AIDS and how they will be getting the treatment, how they will be getting the consultation and all. Now, what are the recommendations for changing the services after COVID-19? Again, these are the standard recommendation. Distribution of the take-home OST drugs for a period of at least 14 days. Distribution of the harm reduction supplies to the client for 1 month. This delivery of the supplies to the client for clients of harm reduction program through mail or courier services. Introduction of the popularization of the test and syringe dispensing machine. Increase online consultation, can be telephone, social network, messengers, hotline. Expansion of the self-testing can be one strategy, and delivery of the ART drugs for 3 months or more. So these are the different things can be done in COVID-19 to reduce the stress among the people living with HIV. Now, we all know that the COVID-19 has a great impact on everyone's life, and presence of the virus has introduced the physical distancing, closure of the school, business, resulting major disruption on our daily functioning. So people living with HIV adjusting with the COVID-19 may have a significant effect on their biological, psychological, and the social impact. The biological impact of COVID-19 on HIV treatment. The people living with HIV whose disease is not well managed are placed at the increased risk for contracting or experiencing the complication related to HIV. Treatment may be interrupted. They may face the increased risk of contracting COVID-19 among the other illness and unable to access to the telehealth services. So these are the biological impact on the people living with HIV. Psychological impact, this is very high, the stronger stress response than the rest of the population due to the increased risk of contracting the COVID-19. The stress during outbreak can lead to the maladaptive coping mechanism, which can include the increased alcohol intake and 2 to 4 times more depression. You must have seen there were news in COVID-19 that increased sexual activity in African females, and they had many cases of the domestic violence in female. So this is very common thing happen, and increased sexual activity due to the lockdown. And consequences of it is the non-adherence to the treatment, suicide, and more workload on the healthcare workers. Social impact was very far-reaching and multifarious. It may be due to the reluctance to engage into the physical interaction with the other, difficulty to connect with the friends digitally, and also struggle to maintain their social bonds. Spending more time on social media site in order to contact with others, this may happen in some cases. So impact of COVID-19 on NSCP program is very high because of the shift in the priorities in the health system affected all the health program. The resources are diverted towards COVID-19 pandemic and resulting in the disruption of our ongoing activities for the communicable and non-communicable disease. Again, the preventive, curative services all over the country got affected due to this. And HIV/AIDS, again, it has to bear the brunt of this pandemic. Now, what are the advice should be given to the people living with HIV in COVID pandemic? It is the general guidelines which are given to the general population, that regular hand wash, maintaining the respiratory etiquette, avoid touching eyes and nose, mouth, stay away from the work, social work, public places, and maintain the social distancing. Then continue to take your HIV treatment regularly. Be adhere to the HIV treatment. People living with HIV but not knowing their status and not yet put on the antiretroviral therapy should start the treatment without delay. People living with HIV who are on treatment should ensure that at least 30 days ARV with them, and wherever possible the stock is available, at least 3 months stock should be given to the all people living with HIV. They should be socially connected with the network so that there will be less stress, less depression. So preparing for COVID-19, I would like to summarize it as that people living with HIV, they should take proper precaution as whatever true for the general people. Avoid contact with avoid going in a crowded places, follow the general guidelines, continue their regular antiretroviral therapy, stock of ART for 30 days. Whoever is having immunization like influenza or pneumococcal vaccine, which has been scheduled, they should take on that date. They should having some plan if they are not feeling well or they have developed some symptoms which is related to COVID-19. So they should contact whom, they should be having that plan. And one thing which is most important, that they should take care properly, take a diet properly, exercise, and in addition to that, they should be properly taking care of their mental health. So lastly, I would like to conclude is that the search of HIV vaccine started in 1980, but no product was licensed so far. We have reached the preventive measures in a remarkable, we have reached a lot. We have achieved the preventive measure and reached a remarkable success. Vaccine against SARS-CoV-2 are the most hopeful way to have a game-changing measures to control the current pandemic. In UK, Pfizer and Biotech achieved the first authorization of mRNA vaccine against COVID-19. In India, Pfizer, Serum Institute, Bharat Biotech COVID-19 vaccine, that is Covaxin, get DCGI nod for the emergency use of authorization. Still, we have a long way to go. We should be having a strong commitment of individual communities, social, civil societies and authorities is required to control this ongoing pandemic of HIV and COVID-19. And I hope that we will achieve this. Thank you very much.
Thank you, ma'am, for your knowledgeable talk on HIV and AIDS control in the new normal. Thank you, ma'am, for showing how HIV care is to be continued during COVID-19 pandemic. Our next speaker for today is respected Dr. Nisha Rilwani, ma'am. Ma'am is Associate Professor and Epidemiologist at Department of Community Medicine, MGM Medical College and Hospital, Navi Mumbai. She is a member of National Editorial Board in People Journal of Scientific Research and also an Epidemiological Foundation of India. Ma'am is also reviewer of Indian Journal of Public Health with total of 17 publications in national and international journals. She is currently in charge of MJPJAY, a government-aided health insurance scheme, and is Infection Control Officer at MGM Hospital, Kamothing. Ma'am, I welcome you and kindly request you to share your presentation.
A very good afternoon to all the participants for today's webinar. First of all, I thank Dr. Saili for introducing me. I also thank MGM Background to give me this opportunity for presenting a session on for today's webinar. I'll be speaking on HIV testing and counseling. But before I start my session, I just want to know whether participants here are awake or they are far asleep. So I can see many participants online. Can I request Dr. Nupur to answer me what is this year's WHO theme on World AIDS Day? Dr. Nupur.
Ma'am, this year's theme is Global Solidarity and Resilient Services.
Okay, thank you, Dr. Nupur. This shows that all of you all are awake. So I begin my session. Now, what will be our objectives for today's session? First of all, we'll be covering what is the background of HIV counseling and testing centers. What are the delivery approaches for HIV counseling and testing? What are the various types of ICTC? How counseling should be done for HIV patients? What is HIV testing? How quality assurance will be maintained while performing testing? And how we will link HIV testing to care, support, and prevention. All these objectives will be covered in my session today. As we all are aware, in Dr. Prasad might have said detail about epidemiology. Half of the people living with HIV do not know their status. Those who know, they often test late, and therefore there is a poor linkage to HTC. Since there is poor leakage, there is linkage. These patients are not transferred to, or they are not referred to ART centers. That means they start their treatment very late. Very late means till the time they are significantly immunocompromised. This results in poor health outcomes. That is why HTC is very important, and scaling up of HTC has to be done. Now, what is HTC? HTC refers to, it's a public health intervention whereby it can be any individual, it can be any couple or family receives HIV testing and counseling on HIV prevention, treatment, care, and support. So these four components are covered in an HTC center. First is prevention, second is treatment, third is care and support. Now, there are HTC, the number of HTC should be rapidly scaled up. How we will scale up? There are various approaches. Number one approach is innovative. Number two is ethical and practical. Ethical approaches already for prevention of HIV has been covered by Dr. Mrunal. Now, for other innovative and practical approaches, we should use some innovative technologies wherein the people have more access to HTC. That should be obviously ethical, and the new technologies should be used so that they come to HTC, they do their counseling, more and more people do their testing so that they get ART as early as possible. Now, why it is important? Number one, so that the people have to have their right to know their HIV status. And those people who are most likely to benefit from the knowledge of HIV can be reached. For example, TB patients, STD infections, and ANC. At the same time, people who want to learn their HIV status should have better access to VCTC, and that should be present in variety of venues. It should not be restricted that you have to travel around 10 kilometers, 15 kilometers just to reach an ICTC. How is the flow of people entering an HCTC? Now, if you can see on the right side of your PPT, there is one photograph. This is a photograph of an ICTC center at Rural Hospital, Panvel. It's a facility integrated ICTC center. Already there is a rural district hospital wherein we have this ICTC. You can see at the entrance, many people, clients waiting for the counseling and testing purposes. Health education material is properly displayed outside. There is actually a proper television which helps to give audiovisual information for the patients or for the clients. It can be approached two ways. One is self-initiated, that is a patient directly coming to HCTC. Second option is when the provider has referred you. It can be any healthcare provider. Here, the patient or the client has an option to opt out. It is up to his will to undergo counseling and testing. Those who have been turned as positive in a screening center, they have been linked to a center that is standalone ICTC where a confirmatory test will be done, and then they are linked to proper to ART center. So this pattern of flow should be followed. Now, there are for HCT delivery approaches. This is a second objective. We have screening facilities. We also have confirmatory facilities. In screening, we are going, everyone knows we are performing ELISA test. For confirmatory, we are going for Western blot test. ELISA helps to pick up the antibodies, and Western blot usually is for picking up the antigen, HIV antigen. Now, for screening facilities, can be in any OPD, IPD, emergency ward. It can be in any PHC, CHC. Or whenever you are putting up an ICTC center as a screening facility in your hospital, it should be followed as per the NACO guidelines. Confirmatory facilities, we have government facilities, we have medical colleges, district hospitals, sub-district hospitals, CHC, we have mobile SAICTCs, target intervention based standalone ICTCs. So these are the delivery approaches by which HCT services, that is HIV counseling and testing services, can be given to the population. All HCT's facilities should adhere to 5 C's. In my entire presentation, I will be giving you emphasis on these 5 C's. Number 1 is informed consent. Number 2, confidentiality. This has already been covered by Dr. Mrunal. She has given many examples how confidentiality by the hospital, by the patients, by the healthcare providers has to be maintained. Counseling is very, very important. Correct test results should be shared with the patient. And connection means linking them to proper further facilities. If a patient is positive in screening, refer him to standalone ICTC. If the patient turns out to be positive in standalone ICTC, please refer the patient to an ART center. Emphasis on these 5 C's is very important: consent, confidentiality, counseling, correct test, and connection. This is a screening facility, how the flow of the patients or how the staff should follow the pattern that is being shared. Again, a photograph which is displayed on the right side, again it's a photograph of Rural Hospital Panvel. This is a laboratory room wherein the HIV testing is carried out. The charts which are displayed actually shows the methods of various rapid tests which are available there. You can see also the cold chain equipment, that is a refrigerator which helps to maintain the HIV kits. HIV kits require a temperature of around 2 degrees Celsius to 8 degrees Celsius. That cold chain has to be maintained. Biomedical waste management should also be done immediately at the site itself. So a few instruments for that are also available in the laboratory. Now, first of all, as and when the patient comes, document the information. Everything should be on paper. Everything has to be documented. What is the patient's name, address, other demographic details has to be documented. Provide pre-test counseling. Before you undertake HIV test, there should be counseling. Like I will be covering what should be covered in pre-test counseling in the following slides. Informed consent. Informed consent, once you have taken consent from the patient, then only you can undergo the test. You can either take the consent when the patient signs, or if the patient is not able to sign, please take the thumb impression, document everything in the registers or the musters provided there. Now, once the patient opts for HIV testing, if he has given consent, he or she has given consent, the patient will go for HIV testing. Once he has tested for it, either the patient will be reactive or non-reactive. If the patient is reactive, please provide post-test counseling. And again, found reactive in the post-test counseling, obviously it's a screening center. You have to link him to standalone ICTC for confirmation. After linkage, that is not the end of the story. You just don't have to refer the patient. You have to again do a follow-up counseling. Partner testing and notification. This I think Dr. Mrunal has completed nicely. She has given very nice examples wherein partner notification testing, she has given some court cases. So it's very important wherein you have to notify the partner. There are few conditions which already ma'am has covered wherein you have to notify the partner. Obviously, if the patient has turned to be non-reactive, then again you have to share the result with the patient or the client. Post-test counseling again is required. So post-test counseling has to be done even if the patient has turned out to be non-reactive. Please make a note. If the patient, now the second part of the story, if the patient has not given consent, you will not end it. You will counsel the patient. You will tell them for the benefit and encourage the patient to do testing. So further counseling has to be done. At a confirmatory facility, obviously, document everything, do the pre-test counseling, take the consent. Patient, if he opts out for HIV testing, similarly, give him counseling for further benefits. If the patient has tested or is ready for testing, link the individual to the laboratory technician, where the laboratory technician will conduct and interpret the results, and the report is signed by medical officer. If the patient turns out to be positive, post-test counseling has to be done. As I've already mentioned, even if the patient is negative or if the patient has shown intermediate report, post-test counseling and follow-up counseling is very important. Link these patients to ART centers. The story doesn't end after just counseling. You have to link them to ART. After linkage also, our story doesn't end. We have to do follow-up counseling, we have to do medical disclosure and partner testing. This all details of this all will be covered in the following slides. The next objective for the day is, what are the types of ICTC? ICTC is Integrated Counseling and Testing Center. Number one, as I have already shown you some pictures of rural hospital, it's a facility integrated ICTC, wherein screening is done. MGM Hospital here at Kamote, Navi Mumbai also has an ICTC, where we also have an ART center. Dr. Chawla had introduced in the earlier session. Now, what is the importance? Why we have to integrate ICTC services in a facility? The main objective is to increase the uptake, to decrease the transportation cost and waiting time. This is most important. It will become patient friendly. If the patient has come already for a DOTS treatment, or if he has come to a chest physician, it will be easy for him if there is a referral from the physician to go to the ICTC if it's within the facility. So it increases the uptake. More patients will approach the ICTC. It will decrease the cost and waiting time. The only requirement is you have to follow the NACO guidelines for creating an ICTC in your hospital. There should be a suitable room with good cross ventilation. Proper signages should be available. Audio-visual privacy should be there. Obviously, as I mentioned, cold chain is important. The kits have to be stored at 2 degrees Celsius to 8 degrees Celsius. We use a rapid test for detecting HIV at screening facility. The second type of ICT is standalone ICTC. Again, there's a picture where is showing of rural hospital. Actually, it's not a standalone, but it's a very ideal room showing where counseling should be done. You can see the charts which are depicted. These charts are all health education material. They should be in local language so that the patient understands. There should be a separate room for counseling. There should be a separate room for the medical officer, and there should be a room for laboratory. So medical officer is in charge of SAICTC. Obviously, you have to train the medical officer. The training is done by State AIDS Control Society. It's a 3 days training. Counselor can be any graduate holder. It can be any graduate from a psychology field, sociology, diploma nursing. One counselor is required for 500 individuals per month. So if the strength of that ICTC is 500 per month, one counselor is more than sufficient. A laboratory technician, DMLT degree holder is important. One is again required for 10,000 annual test load. Now, this is the roles, what medical officer has to do in an ICTC, what are the paramedical staff, what are the roles, and what counselor has to do. Number one point for medical officer, he has to screen. He has to supervise what is going on as an ICTC. He has to plan. He has to maintain the quality. He has to do training of his staff, that is capacity building. Paramedical have to follow the HCTC guidelines and have to give the HCTC package, have to deliver to the patient. IEC, obviously, information, education, and communication should be done to all the patients, maintaining records, maintaining the cold chain, logistic management. Counselor also follows the same roles and responsibility. Additionally, he will also do the counseling services. There is something called as personal identification digit code, that is PID, which is available for each and every patient. Any standalone or facility integrated ICTC has to have a 23-digit code for each and every patient. Now, there are certain guidelines for creating this code. First, we can read the example. Example PW. PW stands, the first 2 digits stand for the type of individual. It can be pregnant. PW stands for pregnant. GI stands for a general individual approaching that ICTC. Second 6 digits are the reporting centers. It can be any SAICTC or it can be a facility integrated ICTC. Third 2 digits are the state code. I've given example of Andhra Pradesh, AP. That is a state code for Andhra Pradesh. In Maharashtra, we can go for MH. Fourth 3 digits should be the district code from where it has been reported. For example, if it is Raigad, I will put RAI. This APR is a district in Andhra Pradesh. Next 3 digits should be the ICTC center number, which is again given by the government. That has to be 001. It's a 3-digit number. Okay. Next 2 digits should be the year of reporting of that particular patient. Here I have put 15. That means it has been reported in 2015. The last 5 digits should be the serial number of that particular patient. So this personal identification digit code is generated for each and every client. If the client has come again for in the HCT, he has approached again, you can use the same number for all the subsequent tests. If that number is not available, you can generate a new one. Now, the third type of ICTC, which has been recently taken up, is public-private partnership ICTCs. Here, the types of ICTC can be market-led, it can be market sharing, it can be data sharing model. So there are three models available for public-private partnership ICTC. Here, obviously, as it's a public partnership, there will be a role of NACO, SACS in all these models. SACS, States Aid Control Society, wherein they have to train the staff, they have to provide technical support, they have to create linkages. Then in market-led model, whatever I've highlighted in red is the difference between all the three models. For example, in market-led model, NACO will not provide any support for commodities. In market sharing model, they will provide support for HIV diagnostic test. They will provide drugs, counseling tools, IEC. In data sharing model, there will be no training, no support. Only data share, only sensitization to the staff will be there. So this is about the third part of ICTC, or the third way of giving HCT services is public-private partnership ICTC. All these have been launched up to scale up ICTC services so that more people get benefit out of it. Next is community-based HIV screening approach. This has been recently launched in the year 2018-19, where we have scaled ICTC services, or we have scaled up HCTC services by providing community-based screening. Now it can be a mobile HCT service. It can be mobile HCTC screening by any ancillary healthcare provider. It can be screening by targeted intervention for prison inmates, which we forget usually, and it should be also available at workplace. So number one is mobile HCTC. It is scaling up ICTC services at the community level. In mobile HCTC, again, the main reason for launching or for bringing up this concept is to reach people in, where they are difficult to access to ICTC, that is to reach the hard to reach areas. It is just a vehicle wherein all testing and counseling services will be provided. Obviously, standalone and facility integrated, both are available. The staff will be the district nodal officer. He will be responsible for the functioning of this HCTC. There will be obviously a counselor, laboratory technician, driver, and cleaner. Mobile HCTC screening by ancillary healthcare providers has also been scaled up. It can be given by PHN, lady health visitor, by ANM, by counselor, by MPWs, peer educator, outreach workers. This is a very important concept, that is screening of HIV by targeted intervention. Now this is led by an NGO. This directs towards high-risk population. What are the packages included? They provide BCC, that is behavior change and communication. They give access to STD services. They help in provision of ensuring safe practices. They help to increase the HIV testing and treatment services, obviously for those who are at risk. Our priority should be 100% coverage of newly registered groups, young people, those who are having repeated STD infections, those having repeated abscesses, those not using condoms. So we are targeting only to high risk group in this, and we are scaling up the HCTC services for them. Scaling up HCT services by targeted intervention is one of the important steps to reach to more crowd and more HIV testing and counseling services. HCTS for prison inmates or prison settings. Number one problem in prison is that they are not aware of HIV testing. For long years, they might be in prison. So number one role is they don't test. So first is we have to do some sensitization to the staff there so that they sensitize the prison inmates and improve the testing. We have to train the staff, and we have to arrange camps regularly or periodically so that they come for HCT services. Once found positive, very important part in prison is linking them to treatment. That means they have to be linked to an ART center. Either we can make a linked ART center at the prison itself, and prison doctor or medical staff there will be responsible for it. Either we can send the patient to SAICS, that is State AIDS Control Society, can arrange some nearby ART center for these patients, wherein the patients can be transported with appropriate security for starting the treatment and getting regular monitoring. So this is an HCT. This again has increased the HCT services at prison level. HCTC at workplace, it has to be provided at organized and unorganized sectors both. Obviously, you have to train the healthcare staff for delivering these HCT services. Only requirement is in HCT, a room where audiovisual privacy, confidentiality, a counselor, a proper laboratory technician can be appointed. Whatever HCTC or ICTC services are beginning at the workplace should follow the guidelines provided by NACO. Now, just a chart which has been taken sources from the Strategic Information Management System. It has been assessed in March 2019. Now, as we have seen in 2007-8, if you see the bar graph, we had only 4,500 standalone ICTCs. 2009, we have started with facility integrated ICTC. We had started with 1,200. And now, in a matter of 10 years, you can see we have increased the facility integrated ICTC centers substantially to 18,000. It's a substantial rise. We also have PPPP ICTCs, wherein we started with thousands and now we are in 4,000s. So this also has increased substantially in the last 10 years. If you see the yellow part in 2018-19 bar, we have community-based screening, which we have started it initially, and we have started with around 2,054 community-based screening for HIV testing and counseling. Obviously, standalone ICTCs, the number has not increased substantially, but the additional or linking up or scaling of the services have been done by providing FICTCs, PPP ICTCs, and CBS. So this is how we have scaled up ICTC, and we are actually doing the NACO is actually doing a very great job by increasing the number of ICTCs so that HCT services can be provided and testing and linkages can be done rapidly. This is a supportive supervision. Just we can go through the slide. NACO or Basic Service Division has to monitor the SACS, that is State AIDS Control, who is in charge of the District AIDS Prevention and Control Unit, under which we have standalone ICTCs. Standalone ICTC is where we do a confirmatory test, and the other types of ICTs, which I've already covered, come under standalone ICTCs, that is FICTC, PPP, mobile ICTC, screening through targeted intervention, testing through ancillary healthcare provider, and other community-based screening facilities. The next part or the next objective for today's session is counseling. Now, what is counseling? Everyone says ki counseling kara lo, but what is it is always a confidential dialogue. Whatever we do in counseling we should not share those results. It's a confidential dialogue between an individual and a counselor. What they actually do, they provide information on HIV so that there is a change in behavior, and a person has he or she takes a decision towards HIV testing. What all is done in counseling? They tell about HIV transmission, they tell about preventive behavior, they also help in coping up if the patient is found to be positive, and therefore I say it addresses the physical, social, psychological, and spiritual needs of the individual. These four components are touched in counseling. So it actually takes, when you have started counseling, it may take hours to counsel one patient. So it is not a matter of 5 or 10 minutes. It takes hours, and it has to be one-to-one. Counseling. Now, there are steps, like it can be pre-test counseling before the patient undergoes test. It can, obviously, whenever you're doing a pre-test counseling, next step is you have to take consent for testing, which I've already covered. All patients, positive, negative, intermediate report, have to go for post-test counseling. We also do follow-up counseling, which I've already mentioned. We have to do additional counseling. In which type of patients you will do follow-up counseling and additional counseling, I'll be covering in the further slides. We have to share the results. Whatever information is given in counseling has to be given in a local language. It has to be tailored to the specific audience or whatever audience has approached the counseling center. Confidentiality has to be maintained. Counsel each individual separately. It should be one-to-one counseling. The patient should be, or the individual or the client should be comfortable and at ease. Do not allow your personal values to influence the history-taking procedure. Employ good communication skills. Use simple language. Use models which can help you to, for example, you can use a model for a condom demonstration. Drawings, IEC materials have to be used. Use neutral language. No offensive or technical terms to be used. Pre-test counseling can be one-to-one, and actually it has to be one-to-one. All patients, all clients have to be given one-to-one counseling. Giving few information for certain type of cohort, like for example, a pregnant female cohort or attending the antenatal clinic, you can give group counseling. But finally, before testing, you have to give one-to-one counseling. Few information can be given in group counseling. Now, what are the contents? What you have to inform before doing the test? First, you have to inform the patient about HIV/AIDS. What are the benefits of doing testing? Keep everything confidential. As I've already mentioned, adhere to 5 C's when you're doing counseling. Patient has an option of opting out, take consent, risk assessment, very important in pre-test counseling. You will understand the importance of doing risk assessment in pre-test counseling at the end. Why risk assessment is important. Give information on hygiene, demonstrate the use of condom, demonstrate why or provide information on why partner testing is important. Some screening we do at the pre-test counseling for STD infections. We'd also do verbal screening for tuberculosis. Give time or give opportunity to the client so that they can ask whatever doubts. There are many myths and misconceptions. All those doubts have to be cleared at whenever pre-test counseling is done. Informed consent. This already Madam has touched. For Dr. Brunal has already covered informed consent. Either you have to take it, take patient signature or take thumb impression, document it. Obviously, this is for adults, but those who are less than 18 years, those who are non-ambulatory, those in coma, their parents, guardians, caretaking institutions, local legal authorities, they have to give consent for the same. Sometimes the healthcare provider, after taking the verbal consent from the patient, can also take the patient for testing. Post-test counseling, as I've already mentioned, if the patient is reactive, intermediate, or positive, has to be conducted. Now, post-test counseling content is same even if the patient is non-reactive or the patient is reactive. The content remains the same. That is risk education, testing the partner, clearing the myths and misconceptions, giving importance on hygiene, linking them to TB or STD clinics or antenatal care. Only difference is, whatever I've highlighted in red, is inform the patient about window period. The patient might have approached the HCT service in window period, where you obviously your test, the rapid test cannot detect the HIV antibody that time. Tell the patient to go for retesting. Retesting is also important for those patients or those clients who have recent infection, wherein again the patient might be in window period, or he or she is having ongoing risk of exposure, for example, a commercial sex worker. Reactive, once you have found that in the screening test, if the patient has turned out to be positive, link him to link him or her, or link the client to a standalone ICTC for confirmation. Now, what you will do or what counseling has to be done when the patient turns out to be positive at an SAICTC. Give him or her time to cope up with emotions, because it's a very dreadful infection. It's a lifelong infection. Once infected, the patient is lifelong infected. And second point, it's a social stigma. So give him time to cope up with emotions. Connect him or her to a social network. Link him to an ART center. Encourage the patient or encourage the client to test the sexual partner and spouse and children less than 14 years. Assess risk of violence, very important. Risk of violence has to be assessed in post-test counseling, and you have to link that patient to a support system. Assess the mental health consequences, such as patient may land up into suicide, or patient may have suicidal tendencies or depression. Assess the mental health component as well, and obviously link him wherever required. As I've already mentioned, even if the patient has a negative report or intermediate report, you have to counsel the patient, retest the patient who has recent or ongoing exposure. In intermediate, you have to call the patient again for retesting in 2 weeks. That is mandatory. So if a patient has tested intermediate, what is intermediate report? I will be covering in my testing session. You have to encourage him or her to come for follow-up counseling and testing in 2 weeks. That is after 15 days. Now, who requires follow-up counseling? We are just using follow-up counseling. There are certain clients who require follow-up counseling after 2 weeks. Number one, clients which are found to be reactive in blood bank screening, but they have turned out to be negative in a standalone ICTC, that is in a confirmatory facility. They have to be counseled to come after 2 weeks for retesting. Those clients, those who are on post-exposure prophylaxis, or those who have undergone in sexual assault, or who are at high risk, or an HIV negative partner of a positive patient, have to be counseled to come after 30 months, because that time the window period opportunity and everything will be over, and the patient can be counseled and tested for HIV, and he may turn out to be positive. Every 6 months. So follow-up counseling has to be done every 6 months for certain type of people. Number one is HIV negative partner of HIV positive individual. Those having high-risk behavior, female sex workers, men having sex with men, transgenders, injectable drug users. Such people or high-risk group have to be counseled every 6 months. Now we have covered what is pre-test counseling, what is informed consent, what is follow-up counseling, what is post-test counseling. There is one concept called as additional counseling. We just don't have to target our counseling towards HIV. We also have to look over other components. For example, for children, for adolescents, we have to look over the component of nutrition. We have to look over the component of immunization. For adolescents and late adolescent age group who are eligible for marriage, we have to go for premarital HIV testing, explaining them condom use, ART adherence for those found to be positive, screening for other diseases as well. So this is an additional counseling component which has to be done based upon what client has approached the HCP service. Sharing of results. Sharing of results is you have to maintain confidentiality, as Dr. Mrunal has already covered. You have to share the results only under following circumstances. Partner notification, which will be beneficial for the partner, that the partner knows the disease early and helps in early diagnosis and treatment. Medical disclosure, and if it is medical disclosure, for example, if the patient is having some other illness, then it is very important. Third, it is also required if it is required by court of law. Now the next part of the session is HIV testing. So counseling services we have covered in an HCT. We will go for testing. Now, as we are all aware, for more than 18 months age, virus can be detected. For children less than 18 months, virus antibodies cannot be detected. Why? Because of the presence of maternal antibody. So the testing protocol obviously for children is different, and for adults it is different. Now, this is certain testing strategies which we have to use at screening facilities for surveillance purpose for obviously adults and children who are more than 18 months. In a patient or a client coming in blood bank for donation or for any reason has to undergo a screening test. Now, the screening test we perform with only one assay. These are all rapid tests. They should be highly sensitive and specific, and they should give results within half an hour. If in assay 1, if the patient turns out to be positive, we label the patient as positive. If the patient turns out to be negative, report as negative. If positive, refer him to a confirmatory facility to confirm the diagnosis. So this is followed at blood banks and screening facilities. For surveillance, we have to use 2 assays. That is, if the patient turns out to be positive in both the assays, then we label that the patient is positive. This, as in public health expert, we should know that for surveillance, we have to use 2 assays. If one assay turns out to be negative after doing the first assay, then the patient is labeled as negative. Now, for diagnosis of clinically symptomatic individuals, we have to use 2 assays and report. If both the assays, assay 1 and 2, are positive, report as positive. If there is a disparity, that is, if there is one assay turns out to be positive and the second is negative, go for assay 3. If assay 3 turns out to be positive, then obviously the patient is positive. If assay 3 and assay 1, that is, if there are 2 assays comes out to be positive, report the individual as intermediate. If 2 assays turn out to be negative, report it as negative. As I've already mentioned, intermediate reports have to be retested after 14 to 28 days. Counsel the patient for retesting. So this is for clinically symptomatic individual where you are suspecting that the patient is having HIV. Before you label him that the patient is negative, go for assay 3. Now, for a confirmatory site where the confirmation of the diagnosis has to be done, we require 3 assays. We will directly go to the interpretation part. If all the 3 assays turn out to be positive, then the patient is positive. If 2 assays are positive and 1 is negative, label the patient as intermediate, retest him. If 2 assays have turned out to be negative, assess the risk. If you remember, in my pre-test counseling, I said that there is something called as risk assessment, which is very important here if you have to label the patient as negative. If you find in risk assessment that the patient has turned out to be low risk, if 2 assays turn out to be negative, you can label the patient as negative. If you find that the patient is at high risk and 2 assays have turned out to be negative, report it as intermediate and retest the individual after 14 to 28 days. So this is at the confirmatory side where you have to use 3 rapid tests. You know about all the 3 rapid tests, like we have TRIDOT, we have Coombs test, what follow NACO guidelines for doing the laboratory investigations. Now this slide looks very complicated, but it is not that complicated. For children less than 18 months, it is very simple. Those children who are less than 6 months, we have to do a DBS sample. What is DBS? We have to do a dried blood spot. If HIV is detected in that, send the baby to a confirmatory facility. If 2 dried blood spot in the screening and confirmatory facility turn out to be positive, we say the baby is positive. And if the baby is more than 6 months old, here you can perform serological testing. But that is not the end. We have to also take sample for DBS. If the patient turns out to be antibody reactive, again you have to do a DBS. If DBS is positive in the screening, go for a confirmatory facility. If both the DBS samples turn out to be positive, label the baby as positive. Why antibody testing is important in children more than 6 months old is, if all the 3 antibody tests come out to be negative, if you can see on the right corner, if all the 3 antibody tests come out to be negative, baby doesn't require PCR technique. So that is the reason we are doing serological test. So even if all the 3 antibody tests comes out to be negative, then baby does not require a DBS. Obviously, you will do a DBS or you will do sampling for those patients who are exposed, that is born to an HIV positive mother or baby referred by a medical officer with unknown exposure status, and you have to classify as per the age of the baby. The next objective, a very, very important objective, is quality assurance. Why quality assurance is important? A false positive or false negative result is associated with social, ethical, medical, and legal implications. Therefore, quality management system is very important, and there should be quality control at standalone ICTCs, FICTCs, and other HCTC. Medical officer plays a very important role in quality assurance. This is the hierarchy, which I've already mentioned in many of my previous slides. Apex laboratory, we have national reference laboratories, we have state reference laboratories, and below it, which we have standalone ICTCs. This is the hierarchy of supervision and quality assurance. There is something called as EQAS, that is external quality assurance system for retesting. Now, each SAICTC have to send or are obliged to send 20% of the positive samples and 5% of all the negative samples which are reported by them in first week of the first month in every quarter. That means all these SAICTCs have to report or have to send samples in the month of Jan, April, July, October. So 4 times they have to send these samples to the state reference lab for cross-checking. Whatever feedback they receive, they have to adhere to it. Okay. Additionally, SRLs also conduct a quality assurance by sending 4 blinded samples to the linked SRL every 6 months. Based upon how they report, they plan for retraining of the staff. So this is how external quality assurance system is maintained. So it is both the ways. SAICTC also have to send the samples to SRL. SRL also sends sample to SAICTC. So this is how, and it is usually done in the confirmatory facilities. The next very important part, or I can say the last objective for today's HIV counseling and testing session, is linking them to HIV prevention, treatment, support, care. Now there is a process of linkage. You have to assess the need, like where the patient requires linkage to the TB center, to HIV confirmatory facility, or to some STD clinic. Identify wherever linkages are required. prioritize the need, where the linkage is most important. Plan where you have to send the patient initially. For example, if what are the timings of that particular facility, what is the address of that facility, identify the barriers. There might be some transportation barrier or any other barriers. Please identify the barrier, counsel the patient. Now, that's not the end. As I've mentioned, once you've linked the patient, that is not the end of the story. You have to take follow-up, receive feedback, and document it. Documentation is very important. This is planning referral, just summarizing the previous slide. Assess the need, prioritize the need, plan, facilitate, and follow up. Now, linking, I've already mentioned. Just go through the 2 slides and then that's the end of the session. It can be unidirectional. That is, from screening facility, you have to link the patient to the confirmatory facility. It can be bidirectional. For example, community-based screening, STD clinics, nutrition clinics, OPD, pediatrics. It can be bidirectional. They may refer to screening, screening may refer to them. Finally, you have to refer them to confirmatory facility. Similarly, for confirmatory facility, we have unidirectional. We have to link the patient to ART center. And it can be bidirectional from the screening facilities or from any other facilities shown on the left column, that is from STD clinics, from nutritional clinics, from OPD, IPD, from targeted intervention groups, from RNTCP. So this is all about, just to conclude, linking, or ANACO is actually doing a very good work by scaling up ICTC, and it is very important so that we increase the counseling and testing services, and obviously linking them to ART or for confirmation, HCT services are very, very important. So that's the end of my session. Thank you very much.
Thank you, ma'am, for your talk on HIV testing and counseling. Thank you for enlightening us regarding importance of ICTC to provide proper testing and counseling for HIV patients. Our next speaker for today is respected Dr. Radha Taralekar, ma'am. Ma'am is currently working as a medical consultant with WHO NTEP for Mumbai and Peri-Mumbai region since March 2020. She had similarly previously worked as medical consultant for WHO NTEP in Bihar and Odisha in 2018 and 2019 respectively. Ma'am has also worked in PATH, an international NGO in Mumbai for private sector engagement for tuberculosis under BMFG, CDC and USAID partners. Ma'am has also worked with Hinduja Hospital for their rural healthcare projects. Ma'am, I welcome you and kindly request you to share your presentation.
So before I begin, I would sincerely like to thank MGM Medical College and Hospital for organizing this webinar and inviting me as a speaker. So today's topic is TB-HIV collaborative activities. So I'll be just quickly, highlighting, what are the collaborative activities that are being taken place at a national level, state level, and national level. So today we'll be quickly looking into the burden of TB-HIV, the national framework for joint TB-HIV collaborative activities, and what are the strategies to improve the access to services, and the coordination mechanism between both the programs, that is the National AIDS Control Program and the NTP, National TB Elimination Program, which was earlier called as the RNTCP. And the service delivery coordination that is happening between the TB and the HIV, and what is the way forward that we are looking as a collaborative mechanism. So first, when we talk about the burden of TB-HIV, you can see in the slide that is based on the Global TB Report 2019 of the WHO, the incidence of, TB cases is around 27% of the global burden. So around, 10 million cases are there of TB cases, out of which in India is around 2.6 million cases. But if we compare the incidence of TB-HIV, it is around 92,000 in India, which accounts for about 9%. And similar, the mortality of HIV-TB is around 9,700, which is around 4% of the global burden, which is quite high. And India is among the high risk, high burden countries, not currently, but it has been there in the list of high burden countries from 2016 onwards. So TB HIV collaborative activities in India are not, very new. They have been happening since multiple years, and it has, evolved over the period. So it was initially, started in 2001, and it was just rolled out in, high burden states. It was later expanded in, other states in 2004, and in 2005 joint training modules were, introduced, surveillance. So it kept on evolving, and in Maharashtra it was rolled out in 2008. And then the major milestone in this, TB HIV collaborative activities in India was in 2009 to 13, wherein, the national framework was revised, and, more streamlined collaborative activities were stressed out. And till date, we have been, that has been the baseline, and we have been, implementing these activities. And in 2012, we had, intensified TB HIV packages, which were, rolled out across India. And in 2014, we had the provider initiated testing and counseling of presumptive TB cases. So this is the national framework for the joint TB HIV collaborative activities. And the main motive behind this is establishment of coordination mechanism at a national level, state level, and at a district level. And the purpose is to have, joint supervision, monitoring and review mechanism, joint trainings, and standard recording and reporting system between both the programs. So the objective of the frameworks was and is to maintain a close coordination between both the programs, that is the National TB Elimination Program and the National AIDS Control Program at all levels, national, state and district level, to decrease the morbidity and mortality due to TB among PLHIV, to decrease the impact of HIV in TB patients, and provide access to HIV-related care and support to HIV-infected TB patients, to significantly reduce the morbidity and mortality due to TB and HIV through prevention, early detection, and prompt management. So this collaborative initiative is based on a four-pronged strategy, that is the prevention, early detection of TB HIV, prompt treatment of TB HIV, and management of TB HIV as a special case. And the main, the underlying purpose is to reduce the mortality due to TB in PLHIV. So there are 3 I's to reduce the burden of TB among the PLHIVs. This has been, repeatedly been stressed on, but I'll just quickly, highlight that the 3 I's are intensive TB case finding at the ICTC, ERT centers. Then the next I is the airborne infection control measures for prevention of TB transmission at HIV care settings. And the third I is the implementation of ICD preventive treatment for all PLHIVs. So this slide is very important. It, highlights that, every PLHIV patient or the client attending the ICTC, FICTC, PPTC's clients will be screened for TB. So we all know, TB is an opportunistic infection, and to prevent the TB related mortality, early detection of TB is very, very essential. And for this, there are multiple strategies that are being introduced. That is, HIV testing will be, conducted in all, whether the patient is, a TB patient diagnosed in a public sector or a private sector, all TB patients will be screened for HIV, and all HIV patients will be screened for TB. So this cross-referral mechanism is, being established and is being implemented. Facilities, that is all the DMCs, the designated microscopy centers under the TB control program, will have HIV testing facilities linked. So either they will have it within the, the same labs, or it will be just adjacent to them. there is a single window delivery mechanism. That is, all the clients attending the ART centers, all the patients will be receiving ART treatment, and through the same window, they'll be receiving the anti-TB drugs as well if they're diagnosed as TB. And all the PLHIVs will have access to rapid molecular testing. That is to know whether the patient is, MTB detected, that is Mycobacterium tuberculosis detected, and also to know the rifampicin resistant status. And this is done by the CBNAT, diagnostic labs, which are available for all the PLHIVs. TB referral services to vulnerable populations. So all the TB patients will be, screened for high risk, and they will be, referred to, based on the high risk, they'll be referred for further screening. And PITC among the presumptive and the diagnosed TB cases. And the center of all these, 6 pillars, we have an IT enabled monitoring system. So we have 99 dots. So for all the TB patients who are initiated on treatment at the ART centers, there is an envelope, and we'll be showing that in the consecutive next slides, wherein there is an IT based, information technology based adherence recording, which is called as 99 dots. So that is the crux for monitoring all the TB patients, especially for patients who are diagnosed as TB among the PLHIV. So this is another new initiative, that is the provider initiated HIV testing and counseling among the TB patients. This has been implemented across the country. And what is the crux of this is that all DMCs, that is the designated microscopy centers, will have co-located HIV testing facilities, that is for early detection of TB cases. We also have the intensive TB case finding and treatment at ART centers. So, the NACO was the first, program to launch the fixed dose combinations for, all PLHIV patients who were diagnosed as TB. So daily, before 2016, we have intermittent course of TB. And from 2016 onwards, we launched the FDCs, but initially, they were launched for the NACO, and then they were scaled up for all the TB programs. So this is a very, very, major milestone. And we also have the isoniazid prophylactic therapy, which was also launched in the same year of 2016. So for the intensive TB case finding, at the ART center, there's a complete package of care. So we have a rapid molecular testing, that is the CBNAT. We have daily FDC, supply, and so patient has to just come to an ART center and he'll be receiving both the drugs, that is the anti-TB drugs, that is the FDCs, and the ART drugs there and there itself. So patient won't have to jump from one center to the other. There is an IT-based 99 dots adherence technology for monitoring the patient's adherence during the entire course of anti-TB drugs. There is pharmacovigilance. There is isoniazid preventive therapy for all PLHIV who are diagnosed and confirmed that they are not diagnosed as TB. We also have airborne infection control for all PLHIV patients. So this slide just shows, the care cascade among the PLHIV at ICTC and PPTC. This is the data from Jan to June 2020. This is a national data. And on the left, you will see the care cascade among the ICTC attendees and the initiation of TB treatment. So around 68 lakh, attendees had attended, the ICTC centers. This data excludes the pregnant woman on the left. And out of them, around 8% were, screened for TB and referred to the NTP program. And out of the referred, around 5% were diagnosed as TB. So that is a good amount of, TB detection. And on the right, you will see the care cascade among the pregnant women. So around, the number of pregnant women, provided pre-test counseling were around, 39 lakh. And among them, around 0.5% of the pregnant women were referred for TB screening. And out of that, 0.3% were diagnosed with TB. Under the collaborative activities of TB HIV, we have a new intervention of community-led prevention. This is a, this document is available online, and it basically talks about, TB screening at all the referral centers. And the main bottom line is to screen for TB at earliest and involve the peer educators and outreach members as a collaborative community-led screening. So this slide basically, shows the trends in numbers and the percentage from 2008 onwards, how many TB patients were actually, screened for HIV. And you can see there is a gradual scale up. So in 2008, only around, 11% of the TB patients were screened for HIV. And now it has been scaled up to around, 2019, it is around 81%. And 2020 data will be, compiled at a national level in around March 2021. But currently, I can say that it is about 90% at a national level. So there is a, bidirectional screening of TB HIV, and this TB patients being screened for HIV has scaled up to a very large extent. And still our target is, we are not still satisfied at 90%. We are still trying our best to scale it up further to at least, 99 to 100% further. So TB HIV collaborative activities are happening at a national level and at state level and at a district level. So at a state level, there is a state coordination committee meeting. There is a state technical working group. And these, quarterly, there are reviews happening at a state level collaboratively with the National TB Elimination Program and the National AIDS Control Program. And there are joint supervision, happening currently with both the department's heads. And similar way at a district level also, there is district coordination committee meeting happening. And there are, review meetings happening at a district level monthly, and joint supervisory visits as well. So next we'll be just quickly, highlighting about the TB HIV management. So we all know that TB is an, opportunistic infection in HIV, especially in India. So all PLHIV patients have to be screened for TB. And the screening is based on the 4-symptom complex. And there have been, multiple studies as to, specify what are these 4-symptom complex. And this is just one, highlight, based on one of the meta-analysis wherein the 4-symptom complex for TB screening among the PLHIV in adults is basically, any current cough, fever, weight loss, and night sweats. And similarly in children, the symptoms are more or less the same, except that, instead of weight loss in adult, we consider poor weight gain in children. And additionally, we consider contact with TB case as a 4-symptom complex among the children with PLHIV for screening TB. This is just a flow chart wherein the patient visiting an ART center will be screened for 4-symptom complex by the care coordinator. And in case patient has any of these 4 symptoms, he will be fast-tracked and sent to the nurse, and the nurse will document all these 4-symptom complex and refer them to the medical officer. The medical officer will, further evaluate clinically and prescribe the further tests or, the medicines, and patient will be, based on the, clinical evaluation, will be decided whether patient needs admission or can be, sent back home. So this fast tracking of this symptomatic patients having 4-symptom complex is basically to prevent, airborne infection. So imagine patients, all PLHIV patients coming together, and among that PLHIV, if there is any symptomatic, he or she might be, transmitting the TB infection to the others. So there is a fast tracking system wherein the 4 symptoms are asked there and itself when the patient enters the OPDs, and based on the symptom complex, they are fast tracked. So counselors are bypassed and directly referred to the medical officer for further care and management. So for diagnosis of TB, the important technology that we have is the cartridge-based nucleic acid amplification under the NTEP, that is the CBNAT technology. So this is a molecular-based, PCR technology. This is the advanced system. It is very, very sophisticated. The advantage over is this molecular technology is that it gives results within 2 hours. The turnaround time is quite, fast. And the added advantage, it gives you 2 things. It tells you about the rifampicin resistance along with the Mycobacterium tuberculosis detection. So it will tell you 2 results, whether TB is diagnosed, whether MTB is there or not, and about the rifampicin. So based on this, our treatment protocols can be customized. It is highly sensitive, specific, and all samples can be sent, like pleural tap or ascitic fluoride or CSR, CSF, except blood, urine, and stool. So all samples, even a tissue sample, can be sent, and it can be processed and further run on CBNAT lab. So this is just a diagnostic algorithm. It might look complicated, but it is very, very simple. So all, diagnosis of TB should be based on nucleic acid amplification test. So that is the CBNAT or the TrueNAT. That is the new technology. So on the left, you can see the presumptive TB. And in that box, you can see PLHIV. So PLHIV is a high risk group. So all patients of PLHIV who are presumptive TB are suspect with 4-symptom complex will be directly referred for NAT testing. So we don't undertake smear examination for PLHIV. They are directly sent for NAT testing. So NAT, that is the CBNAT or the gene expert, what we call it as. And the NAT will give you 2 results, whether it is MTB detected or not detected. If it is MTB detected, it will further give you 2 results, that is rifampicin resistance detected and rifampicin resistance not detected. And as per the NTEP program, all patients who are diagnosed on NAT testing are further subjected to first line LPA and second line LPA and culture DST. And based on the resistance pattern, the next treatment protocols are prescribed for the patient. So currently under the NTP program, we have the 4 FDCs. So now there is no more CAT1, CAT2, CAT3 and CAT4. There is no more CAT. We just have FDCs, fixed dose combinations, and this is given on a daily basis. So there is no more intermittent drug regimens for TB control and management. So in the FDCs, the fixed dose combination, each pill will contain isoniazid, rifampicin, pyrazinamide, and ethambutol. So this is the weight band for the adults, that is based on the weight band. So imagine a TB patient is having a weight from 25 to 34. This is in adults above 18 years. They will be given 2 pills per day in the IP phase and in continuation phase 2 as well. So similar way, from 35 to 49, 3 pills. From 50 to 64 kgs, the patient will be receiving 4 pills, and patients weighing between 65 to 75 kgs will be receiving 5 pills, and any patient above 75 will be receiving 6 pills. If the patient is not tolerating, 6 pills, we can reduce it to 5 pills per day. Similarly, this is a picture of 3 FDCs. The 3 FDCs are given at the continuation phase and they're slightly smaller in size. So for the PLHIV patients, all these FDCs are given at the ART center itself under the single window system. So these are the pediatric pills. In the pediatric pills, they are dispersible. So they can, be dissolved in the water and the child can just drink the water instead of swallowing the pills. And on the right, you will see the weight bands for the FDC dispensation in pediatric age group. So again, it is based on the weight band, like 4 to 7 kgs. Child will receive, 1 pill of HRZ and 1 pill of ethambutol. Ethambutol is not dispersible, so it is, available separately. So either the patient will have to, swallow it, or will have to be, crushed, or, sometimes it is just, kept in a banana and the child is told to just swallow the banana. So this is the new technology, that is the 99 dots that I was talking about. That is an IT-based technology used for maintaining the adherence for all patients who are receiving the FDC. So this is an envelope that is being, put under the strip. And when we turn around, you will see a, pictorial, circle wherein there is a picture of telephone. So patients will have to, pull out the pills, and once they pull out the pills, there will be a toll-free number, and patient will have to call this toll-free number and will hear a thank you note. So once the patient hears this thank you note, the adherence is recorded back end in the Nikshay portal that is used for monitoring the patient's adherence. So this will give you kind of, back end information whether the patient has consumed his anti-TB drugs daily. So patient needn't come to the center and consume their drugs in front of the healthcare worker. So the next step that we have is the isoniazid preventive therapy for all PLHIV patients. So first thing is that we screen all PLHIV patients for TB. If they are not diagnosed as TB, then we prescribe them as isoniazid as a preventive therapy. So the main objective is the isoniazid is an effective, bactericidal anti-TB drug, and it prevents the progression of latent TB infection to active disease. So it is to be given to all PLHIV patients. The only contraindication is that if the PLHIV patient has, active tuberculosis disease, then it is not to be given. If the PLHIV patient has, active hepatitis or peripheral neuropathy, or has poor adherence to cotrimoxazole, or, has been, in contact with an MDR patient, or he or she has just completed the drug resistant treatment, in those cases, IPT is not to be given. So IPT is to be, given immediately after ruling out, active tuberculosis. But in case that, the PLHIV patient has, just been diagnosed as HIV and the ART treatment has not yet been initiated, in those circumstances, first we initiate the ART treatment, and after 3 months, we start the IPT. So that is a delayed IPT. And the reason behind is, the chances of, subclinical TB is less likely after 3 months of ART. So that is the reason that we have a delayed IPT protocol. And the risk of ART-induced neuropathy and hepatitis is as well reduced. So the IPT regimens are very simple. In adults and adolescents, we give isoniazid 300 mg plus pyridoxine 50 mg. And this duration of IPT is to be given for 6 months. It is a daily regimen, a single tablet. And children about 12 years, about 12 months is prescribed as isoniazid 10 mg per kg per day plus pyridoxine 25 mg. The duration is again for 6 months. And this IPT is given again from the ART center. So the patient doesn't have to jump from one center to the other, but it is all provided at a single point. This is the pediatric dosing charts for the IPT. So on the left, you will see the weight bands. So below 5 kg, half a pill is given, that is around 50 mg, and 5 to around 9.9, one pill, 10 to 13.9, 1.5 pill, 14 to 19.9 kgs will be given to tablets of isoniazid, and from 20 to 24.9, 2.5 tablets, which is around 250 mg, and about 25 kg weight, 3 tablets or 1 adult tablet, which is around 300 mgs of isoniazid. So the key points to remember at this session is that TB is an opportunistic infection among PLHIV in India, and the main purpose is to prevent TB related mortality and ensure early detection of TB. And detection of TB is through molecular diagnosis like CBNAT, and screening of all the PLHIV patients for TB is based on the 4-symptom complex. And the purpose is for early detection of tuberculosis. So the way forward at a national level, we are trying to saturate the coverage of IPT among all PLHIV, which is not, currently it is around 60 to 70%. So we try to have that saturation to almost 99 to 100%. And all states to conduct a coordination committee meeting regularly at state level and at a district level as well. Monitoring the cascade of ICTC, PPTC, and the ART centers and TIs and prisons. Scaling up provider-initiated HIV testing and counseling across the country among the presumptive TB and cases including the private sector. This is a major thing that we are including the private sector as well. And joint visits by the SACs and the state TB cell. So thank you all. So it's time to unite and collaborate and fight TB and AIDS together. Thank you, and over to you.
Thank you, ma'am. Thank you, ma'am, for your highly informative session, and also for sharing your immense knowledge on network between TB and HIV programs. We shall now proceed to a question and answer session. Dr. Prasad sir, I kindly request you to address our question and answer session.
Well, thank you, Siley. Actually, we are running behind the schedule. However, we have been noting the questions all we are receiving in the chat and the question answers, and some of the questions have been already answered by Dr. Shrikala before Dr. Madhvi's session. However, one point which has been asked in some of the questions which I would like to take up and an answer on that, and that is regarding the children living with HIV. Now, what you need to understand here is that prevention of HIV or AIDS in the children, it begins with the prevention of transmission from mother to children, PMTCT, and we need to focus on that. So that is the first point. Second is that obviously we do have a proven drug, nevirapine, which has been used at the birth in that case, that helps into the prevention. As well as Dr. Madhvi has suggested that in the new normal also, it has been recommended that in the first few weeks, we should attempt to give the nevirapine in such cases. Now, when these children, they're small, what about the breastfeeding? And should it be stopped? That is the question which also arises, and many of the participants have asked about it. Now, about this WHO and the UN agency guidance is very clear, is that actually the disadvantages of not giving the breastfeeding are more, and it is more harmful to avoid the breastfeeding. So the breastfeeding has to be continued. So that is very important, and that should be the clear message. At latter stage, obviously, Dr. Nisha has already mentioned that how to test about HIV positivity through the various testing algorithms. And then Dr. Radha has also pointed out the possibility of these children catching tuberculosis and then how that should be tackled. So I hope that this issue has been well addressed by all the speakers, and I hope that that satisfies the questions. So coming back to you to wrap up the session, Dr. Saili, please go ahead.
Thank you, sir. I would like to thank all our speakers for sharing their knowledge on HIV and AIDS and enlightening us with recent advances in the same. Thank you all, or thank you to all our attendees for attending our webinar today and making it successful. I thank Dr. Usha Rai ma'am for being the observer for our webinar for Maharashtra Medical Council. Thank you ma'am for gracing us with your presence. Thank you. We shall be closing our webinar now.